Well, good morning, everybody. My name is Dwayne Dyson. I'm a pediatrician down in Tucson, Arizona, practicing in private practice. Welcome to the 7th annual Arizona Men's Health and Wellness Initiative. This time we have the privilege of being able to do it by Zoom, so everyone can be relatively comfortable in their own place. We have two topics we get to go through today, which should be interesting and fun. One is going to be about prostate cancer, leading off the morning, and then followed up by diabetes. So with that, I'd like to pass it on to Brother Myron Douglas.
Thank you, Dr. Dyson. Good morning,
Mhm.
everybody. Let me just kind of begin and kind of give you a brief history about this project. This concept for this project began over dinner at IHOP between 7 men on November 7th, 2011, here in Phoenix, Arizona. Someone at the table mentioned that it will be a good idea to have an open dialogue about our health, men's health. We discussed some of the challenges in learning how to manage health issues, getting checkups, and just being proactive about taking better care of ourselves. During this discussion, we also brought up how do we care for our families when a health concern occurs. From that evening conversation, we started to plan, research, and prepare to develop a platform where men can feel confident about having conversations about their health, where men can speak with doctors, physicians, and other medical experts about questions or doubts that they may have about their health concerns. An event where men can meet and establish a connection with a doctor to talk about treatment if needed. After several months of meetings, late night conference calls, and a lot of paperwork, finally we came up with something. On June 16th, 2012, the first annual Arizona Men's Health Awareness Expo took place at Scottsdale Healthcare, which is now Banner Health in Scottsdale, Arizona. We had 30 participants, 4 panelists, and our first awardee was the former Phoenix Council member, Michael Johnson, which also is a prostate cancer survivor. Once the event was over, we saw the potential to grow it, make it a real benefit for the community. In 2014, we were blessed to partner with the Mayo Clinic, the nation's best hospital by U.S. News and World Report over the past 3 years. This helped to expand the program's presence within the healthcare community. And with that, we partnered with our parent organization, Sphinx Educational Fund, community volunteers, and Mayo Clinic resources, who was able to take the expo to the next level. Through the years, we continue to partner with other health community organizations to share information on health topics. These partnerships include the National Kidney Foundation and NAMI, the National Association on Mental Illness. Now, in our 8th year, we are preparing to adapt to an ever-changing environment, to provide an online presence by having virtual quarterly events, using social media outlets, and our new YouTube channel. With the current COVID-19 pandemic, it is so important now than ever before to stay educated and aware on health issues, to protect yourself and your loved ones. We will continue to provide the platform for communication to keep men and their families informed. I know for myself, I learned something new at each men's health event we host. With that being said, enjoy today's virtual event, take notes, ask questions. I want to thank all of our sponsors, community partners, and panelists for making this event possible. Now we'll turn it back to Dr. Dyson and continue with the program.
Right, great introduction. So our first two speakers we have speaking on the topic of prostate cancer are going to be Dr. Cassandra Moore, who is a Princeton graduate, psychology degree back in '94, and then went on to medical school and complete her training there at the University of New Mexico School of Medicine in '99, and then on to the University of Massachusetts, where she did an internal medicine residency, and then on to do a fellowship in Duke at doing hematology and oncology. So she joins us, and she's got experience in private practice, but also she returned to Duke after her years in private practice, and currently is a clinical associate working with Duke Cancer Network and DCI GU Oncology Research. So welcome her. And then we also have Dr. Edmund Baker, Jr., fraternity brother of mine. Appreciate that. And he took a non-traditional route into the field of medicine. He actually spent 15 years working after being in the U.S. Army and worked his way up to be the first African American account manager for automotive products. And then he transitioned from that life into the field of medicine, which is great because we appreciate him in the field of medicine. So he completed his undergraduate degree at Temple University and then on to University of Michigan Medical School for his medical degree. I did some postgraduate training there in the Phoenix Integrated Residency and Obstetrics and Gynecology program in Leahy Hospital and Medical Center, formerly Leahy Clinic. And so with that, I'm looking forward to hearing the inspirational insight to what's going on currently in 2021 in prostate cancer and how people can become not just more informed, but take steps to ideally improve their status, their health, and going forward. Dr. Moore and Dr. Baker.
Good morning, everyone. If I could just have the privilege of being able to share my screen, I can get started. It is an absolute honor to be able to present with Dr. Moore, who is actually more of an expert in this field than I. I come to this from the lens of a primary doctor and what you should be talking with and what you should expect with your primary doctor. So as that is, hold on, just make sure we have this, as that is understood, I will get going by sharing my screen. And there we go. So just want to start by just saying, prostate cancer is something that men don't like talking about. We dread going to the doctor, all the horror stories about how to be tested and all of that just leans heavily on us, but this is something that we need to do. So what I want to do is just give a little bit of background as to what a prostate is. Most people don't even have that understanding. So I just wanted to show a little diagram of this walnut-sized gland. As you can see the cartoon here that shows it uh, very well displayed as it sits between the bladder and the base of the penis, and it stands in front of the rectum. And this gland's purpose is to provide fluid for the semen, and that's its primary function. Some of the problems that you can run into with the prostate during the lifespan is, of course, prostatitis, which is pretty much just an infection of the prostate. It's not very common. There's a benign prostatic hypertrophy. Just as you notice from the first bullet point, the prostate can grow the entire life of a man. And if it grows to a point where it's actually causing problems with urination, the passing of urine through the prostate, that becomes a problem, and that's benign prostatic hypertrophy, which can be treated with medications. And then what we're here for today is to talk about prostate cancer. That is definitely something that can happen. And as we get deeper into the subject, we'll learn more about that. So the screening of prostate cancer. Just so everyone understands, this is the second most diagnosed cancer in men. It is a 12% lifetime risk, which works out to be about 1 in 8 men will have a diagnosis of prostate cancer. African American men are twice as likely to have this diagnosis. And also people that have family histories of prostate cancer, especially if it happens early on in life, will have an increased risk. And then there's those that have a family history of the breast cancer gene 1 and 2 can be at increased risk as well. This is something that when you come to your doctor's office, they should definitely talk about, are there any cancers in your family? We don't ask that question to be nosy, is so that we can understand what we're dealing with on any just normal visit. And so that we can talk to you about how screening should happen. So what is screening and what's the role of screening? So anytime we say screening, the goal is not to diagnose, it's to take a group of people that have a certain risk and to look and see if they possibly have a disease. And in this case, we're talking about prostate cancer. So we're not going to look at people who are going to be 20 years old because they don't sort of have a risk for prostate cancer at 20 years old. So this usually starts later in life at 50. But as I talked above, if you fall into a category where people have increased risk, such as African Americans or those with family history, then screening can happen earlier. And again, this is a discussion that you should have between you and your provider. And the goal of doing any screening at all is to reduce the risk of mortality. Mortality is just dying from the disease. The good thing about this disease, it does move slowly. So men who are reluctant to show up to our offices and be screened, uh, it is a good thing that it is a little slow, but in the populations like African American males and those who have other genes like the BRCA gene, it can be very fast and it can be a lot younger in age. So please stay in touch with your doc, see a doc every year, and just talk about these things. So types of screening that are available for prostate cancer, and this is always been a back and forth. When I started practicing, it was the digital rectal exam. No man wanted to do that, but it was necessary. Then the favor fell towards prostate specific antigen, which we call the PSA. Uh, it goes back and forth. Some experts only believe that PSA should be done in people with increased risk. Again, this is very important that when you have the conversations with your primary doctor, that you discuss these in a very strategic manner to understand what you should be doing with regards to screening for prostate cancer. And what makes this disease so problematic is most people with it don't know they have it. Again, when we talk about benign prostatic hypertrophy, the prostate gets bigger and it creates problems. You start having issues with some people with discomfort, some people with problems with urination. Well, the parts of the prostate that really are affected by cancer don't necessarily cause those type of symptoms. So you can go a long time without knowing that you indeed have an issue. So it's important to be screened. It's important to be risk stratified. And once you are believed to have an issue, you should have a biopsy. Biopsy is how this is diagnosed. This is when you take a needle and you take a piece of the prostate out, and it then is looked under a microscope. And we determine at that time whether you have prostate cancer or not. Uh, at the time of most people's diagnosis, 78% of them, the cancer is still located within the prostate. That's what localized means. For 12% of people, it's gone beyond the prostate and into the lymph nodes surrounding it. And then in a small percentage, the 6% of people, is gone distantly into outside the lymph system and into other organs. This is where we really want to catch it localized. If not localized at the most at the lymph node stage, what we don't like to see is when it gets out and is everywhere. It could be in your lungs or any other part of your body. So this is really important to have these discussions about screening with your primary doctor. I'm going to pass the mic over to Dr. Moore, where she will begin to talk about the the pathology of cancer and treatment options.
Yes, thank you, Dr. Baker. I appreciate, again, the opportunity to speak with you all today. And I appreciate the opportunity to share my time with Dr. Baker, who's excellent and has done quite a bit for the community, not only in prostate awareness, but also with COVID and everything else. So I appreciate being able to share this time with him. I will go ahead and share my screen as well. And we'll sort of reiterate let me see here, reiterate the some of the and sort of emphasize again what Dr. Baker had mentioned about some of the importance of screening and how that plays in from my standpoint and as an oncologist. So if I can get this thing situated, then there we go. Okay, so prostate cancer again is the most common cancer among men, and that's after skin cancer. So as Dr. Baker said, it is the second most common cancer among men. However, skin cancer obviously is usually quite localized and treated with a dermatologist. So prostate cancer can also often be treated successfully if it's diagnosed early. And that is very key because if you see the 5-year survival rate for localized or regional disease, and regional, as he had discussed, was to lymph nodes, is really approaching 100%, whereas the 5-year survival for distant disease is only 30%. So that is really key and really emphasize the importance of early screening and detection. So the overall 5-year survival rate for prostate cancer in general is 96% in African American men and 98% in non-Hispanic whites. Specifically for African American men, they have the highest death rate and shortest survival of all racial and ethnic groups in the US for cancer, unfortunately. The death rate for prostate cancer in African American men is actually 2.2 times higher than non-Hispanic white men. They do have the highest cancer rate. It's estimated that 1 in 7 African American men will be diagnosed with prostate cancer compared to the average 1 in 8 white men. And then prostate cancer is also the second leading cause of cancer death in Black men. However, there is some good news in that prostate cancer death rate has dropped by more than 50% since the early 90s, and that's really due to improved treatment and early detection. For Hispanic and Latino men, actually prostate cancer is still the most commonly diagnosed cancer in Hispanic men, but the incidence rates are actually slightly lower than non-Hispanic whites. So you're looking at 92 men for every 100,000 diagnosed versus 102 per 100,000 for white men. Death rates are actually also slightly lower in Hispanic and Latino men than in non-Hispanic white men, although there is some variation with subpopulation. So it's notable that Dominicans actually have death rates that are twice those of Mexican and Puerto Rican men versus, as well as non-Hispanic white men. So the 5-year survival rate for Hispanic and Latino men is actually a little bit better overall for as compared to the other racial and ethnic groups, with 98% localized, 96% with regional disease if it's gone to the lymph nodes, and 35% if it's distant disease. There are lower rates of the common cancers in Hispanic and Latino men, but however, disproportionately higher rates of cancers related to infections like liver, stomach, and gallbladder, which we'll save for another day. So risk factors for prostate cancer, well-established risk factors, as Dr. Baker mentioned, are African ancestry, advanced age, family history, and also there are some associated genetic syndromes like Lynch syndrome, which is usually most associated with colon cancer, but also prostate cancer is related to that as well. So there is also increasing evidence suggesting that obesity and smoking are associated with increased risk of aggressive disease, and that is particularly the case in African American men. The American Cancer Society recommends beginning at age 45 for Black men that you should discuss with your doctor about PSA testing. And as Dr. Baker had mentioned, there has been a lot of debate about PSA screening. It probably, there was a big push for PSA screening, and we did find a lot of cancers. The question was, did we find some that were behaving more less aggressively and may not need to have been treated? And so there's been some debate in the U.S. Preventative Task Force, which sort of oversees recommendations for screening on a population base, like Dr. Baker had mentioned. We're really looking at groups of people and its benefit, had started arguing against PSA screening, but we actually have data now that's coming out showing that there are more men presenting with metastatic prostate cancer. And I can imagine and would probably feel that we could get data to support that is a side effect of that decreased PSA screening that's been performed. So it is very important for each individual to talk with your doctor about your risk and the benefits and whether you want to proceed. So it's important for Men's Health Expo not only to focus on disease, but also to focus on health. And to that end, prostate cancer and as well as all cancers, if you look at 42% of newly diagnosed cancers can potentially be avoided, and with just changes in 19% are caused by smoking, and then the 18% are caused by a combination of excess body weight, lack of exercise, poor nutrition, and alcohol consumption. So those are really areas that we can impact for almost nearly, half of diagnosed cancers. So live life healthy. Why is this so important? So the foods that you choose to eat and the amount of physical activity you get can impact your health as well as your prostate cancer risk, recovery, and survival if you do happen to be someone diagnosed with it. Recent data suggests that obesity, which is diagnosed as a BMI greater than 30, as well as smoking and uncontrolled medical conditions like diabetes, are associated with more aggressive prostate cancer and worse outcomes. Studies also suggest that a healthy diet and regular exercise may lower your risk for prostate cancer and help you prepare for and recover after cancer treatment, and then prevent your cancer from coming back if you are someone who's been diagnosed. So diet and exercise may also help with treatment in several ways. Physical activity can improve your physical and emotional health. It's important for managing weight, maintaining muscle, reducing the risk of heart disease, and keeping your bones strong. And you can stay active with balance. Staying active can help with balance, improving your sleep, fatigue, and anxiety. We know that stress, leads to a chronic inflammatory state, which can increase your risk of disease development and even cancer. And also declining or low physical activity is associated with increased fracture in older men. Poor physical function can be related to low bone density. And then specifically my patients that I deal with, men with prostate cancer receiving androgen deprivation therapy, exercise and nutrition can help them maintain strength. So muscle burns up to 50 times more calories than fat. So if you increase your muscle mass with strength training and aerobic exercise, you can raise your resting metabolic rate, which can prevent weight gain or even help you lose weight. Strength training is also important for maintaining healthy bones. And the aerobic exercise doesn't have to be going to the gym, or playing a formal sport. You can engage in hobbies like bicycling, gardening, walking. All of those are beneficial. So everybody always wants to know, is there some food that I can take that will prevent me from getting cancer? And there's a lot of studies going on looking at different nutrients that might help fight cancer, but there has not been one that's been identified yet. And so it's really just always best to get your nutrients from whole foods rather than worrying about a ton of supplements. And it's really important to aim for a healthy eating pattern rather than focusing on specific foods. So if you eat at least 5 servings of fruits and vegetables a day, you go for the fruits with the deep bright color, consider eating fruits and vegetables for snacks. If you're choosing whole grain breads instead of white bread, limiting red meat, including beef, pork, lamb, and goat, and limiting processed meat, like bologna and hot dogs and sausages and things like that. Fish, skinless poultry, beans, and eggs are really healthier sources of protein. And you can choose healthful fats like olive oil, nuts, and limit your saturated fats from dairy and other animal products, as well as avoiding trans fats, which are in a lot of fast foods and packaged foods. Avoiding sugar sweetened drinks and saving them for an occasional treat, cutting down on salt, which is also huge for blood pressure, which is a big issue, and washing portion sizes. So this is just a little summary slide, but we've discussed all of this already. The one thing I would highlight in terms of alcoholic beverages, if you consume them at all, the recommendation now is that women should have no more than one per day, and men should have no more than 2 drinks. So that's the only thing to add from this. So I'm happy to talk briefly about some prostate cancer treatment. I'll go over what's sort of going on, and then more excitedly, what's really coming down the pike. So, if you are diagnosed with prostate cancer, there are options. If you present with local disease, often you'll be offered consultation with surgery and radiation oncology. So surgery can be done open or robotic. Usually there's some temporary incontinence that's common, but any permanent incontinence is less of an issue typically. Erectile dysfunction is very common because they're having to interrupt the nerves during the surgery. But most patients with clinically localized disease can be cured from surgery. And there are now some emerging surgical technologies like focal therapy that are currently being studied and may, choose to continue to develop for a larger group of people. Radiation therapy for prostate cancer, there are many types. At Mayo, which I now am, there is proton beam therapy. A lot of people wonder whether that's actually better than IMRT, which is a sort of a modulated radiation therapy. There are randomized trials going on looking at this. If you were to be diagnosed with prostate cancer, you would have a consultation with a radiation oncologist who could go through all of the different varieties, because this is another area, obviously, of treatment that is advancing and really becoming more tailored to treat with less and less toxicity. A brief history, this is just to sort of show that from 1941 to 2010, there were only 10 drugs approved for prostate cancer over that period of time. And then the same number of drugs plus 2 different imaging tests were approved from 2011 to 2020. So we're really accelerating in terms of the advances that we're making in prostate cancer treatment. And really what's ahead, it's going to a warp speed in terms of new developments in treatment. We're looking at immunotherapy for cancer, for prostate cancer now. Just in December, there was a new diagnostic test, PSMA test, which is imaging for prostate cancer that's very sensitive, and that was just approved. We have other, hormone therapy strategies that are being developed, and then really, looking at whether, as I mentioned, nutritional things, if there's something specific in diet and nutrition beyond what we know now, that's being studied, as well as your gut flora, and then just understanding how different people and different groups of people sort of process drugs, and how those, the benefits vary among population and between individuals. So we can really target who will serve best with which treatment, and that's the goal. So very, important, as Dr. Baker had mentioned, BRCA1 and 2 genes. We've really realized that genetics plays a huge role in prostate cancer, as with many other cancers. Really, every man with advanced prostate cancer needs to have his inherited genetics checked, and that's a standard of care now. So, if you were to be diagnosed with prostate cancer and you're speaking with your oncologist, genetic testing should be part of that conversation. 15% have an inherited cancer risk gene mutation, and that was identified in a Mayo Clinic study. We know that the findings of if there was a gene mutation identified, that would not only impact the patient and potential treatment for him, but also his family. The most common prostate cancer associated gene is BRCA2, which is also associated with breast, ovary, and pancreas cancer. And we now have targeted therapy against that gene in PARP inhibitors that can be very beneficial for treatment of these diseases. Um, and then we also can, in addition to testing what we call germline mutations, which travel through families, there's also genetic testing that can be done on the tumor. So as we treat the disease, we can determine which mutations that it is developing or different ways around our treatment, and we can find new targets to go after in treatment. So on the right here, I won't go into them at length, but there are many different genes that actually affect therapy, and so that's a very important area of research currently in prostate cancer. And then this is just to show that, there are 1,653 active trials in the registry, U.S. Registry of Clinical Trials for prostate cancer. So we are continuing to really push the bar ahead in terms of treatment options and improving, outcomes for men with prostate cancer. It is important. I'll give my little note here that it is extremely important for men of color to participate in clinical trials. We want to be sure that the findings that we're getting, that we can actually use that information to the benefit of all communities. And if we're not represented in the trials, we can't have that knowledge. So with that, I will unshare my screen and leave it for any questions or Dr. Baker to add anything.
Yeah, nothing to add. Again, just absolutely amazing hearing you talk, and the knowledge that you give is just absolutely spot on. So, turn it back over to the host, Dr. Dyson. There's Dr. Dyson, we can't hear you.
Oh, I'm sorry. Say that one more time, please.
I was saying we were just turning it back over to you for the questions, if there were questions.
Sorry about that. Hit the wrong button.
Mhm.
Yes, if there are any questions, feel free to throw them into the chat. But I did have a question, even as the MC had a quick question. Dr. Moore and Dr. Baker, great presentations. Dr. Moore, it seems to me that the crux of the health benefits in terms of proper diet, nutrition, exercise, keeping stress down, keeping the BMI under 30, all that ties into more of an anti-inflammatory state. But yet you start off mentioning that supplements would not be much of a benefit. But based on that, I would think foods, garlic or vitamin supplements, vitamin C and other antioxidants could serve some role in helping, just like, as I said, nutrition and exercise. Any thoughts on that?
Sure. So it's not that, so I guess my point is that it's because we have been looking, we've been doing a lot of different studies trying to find that one perfect supplement. And nothing to date has really shown evidence that yes, this is the gold, right? And so it's rather than having to have someone worry about, am I taking this right supplement, or spending a lot of money on supplements that we don't necessarily have data to support, that just focusing on what we know we can do until we have more data in terms of really trying to have a broad diet and getting a lot of those green leafy vegetables, and limiting that. We know that, higher saturated fats, higher BMIs are linked to cancer. So let's focus on what we know. If you want to talk to your doctor about individual supplements, I have no problem with that. Mayo Clinic also has an integrative group which can help sort of give more real-time data about supplements. My point was just that, not to feel that there's one um, target golden bullet, but to look at it overall lifestyle.
Thank you.
Mhm.
All right, hold on one second. Winston Whaler, Brother Whaler asked me to pause for a second so you can reclaim something. I'm seeing if he's back in play. Hold on just a moment.
We're good, Brother Dyson. I do have a question in the chat from Dr. Jason M. Kalaman. Are you able to see that, or do you want me to read it out to you?
Oh, I can see it. I'll gladly read it.
All right.
Dr. Moore, this question's for you from Dr. Kalaman. What do you attribute as some of the primary causes of prostate-specific health disparities with people of color? And is it just education or exposure to health benefits?
Sure. So, a good question. I'm sure Dr. Baker, if you have anything, feel free to jump in. So, this has been studied quite at length, and it really is a multifactorial. There's many reasons that contribute to it. So, you can, there's definitely, if you look at a genetic level, and we're not talking, so, as we all know, a race is really a social construct. So we're looking at the genetics. So everybody, there's a variety of genes expressed in all of us, and you can trace some of those back to, different ancestry. So there's probably a biologic component to some extent, because they have even done studies sort of tracing along the slave route from Africa through the Caribbean and into the U.S., and looking at different varieties of prostate cancer and aggressiveness of that. But there is also, the social determinants in terms of, access to care. Some of these biases, we talk about unconscious biases of interactions. There have been studies that show that Black men get less aggressive treatment even when they have access and are face to face with the provider. They're getting suboptimal radiation treatment, or different things like that. So it's a huge issue, and there's been a lot of study going on teasing out the different causes. But everything from, we try to address the health education and knowledge. Men in general tend to be sort of in the back seat in terms of their health. So taking a more aggressive approach to managing their own health is not only important for Black men, but for all men. And access nutrition, it's a myriad. Dr. Baker?
Yeah, absolutely. And even though I'm an OBGYN by training, the first paper I ever published, and was published in the journal Cancer, was about prostate cancer. And it was about this actual fact that Black men chose to have the less effective treatment. This was published back in 2005. And we never came up with a reason why. We just pretty much published the data. But one of the things that I talk about in my lectures, because I actually lecture on disparity of medicine, is those social determinants of health do play a big role. Biases, implicit biases are huge. There's been studies that show that people of color go to the emergency room, and get less analgesics for their pain, even though the doctor can verify pain and can understand that the pain levels are high, they still get lower doses of medication. So these biases are in play, and we just don't know all the different ways that they play out. I'll be speaking about some of them later on this afternoon, but very good question. And again, this is a lot of room for future study.
All right, one more, I see other questions coming in. One is the point Dr. Moore made about the Dominicans having a higher rate, basically even higher, than the Mexicans and non-whites in terms of prostate cancer. And the question is that related more to their African descent?
Right. So this was a study done in Florida, and that raises that suggestion. It would seem that with given that the presence of the African ancestry in the Dominican people. But I don't know that the study was just really looking at, again, as Dr. Baker had said with his study, looking at identifying the differences rather than being able to define causality. But that would be a very interesting area of study.
Okay. Another question here is there a test or screening at Mayo I can take that detects cancer, which primarily affects men? Yeah, either you, Dr. Moore, or Dr. Baker.
Yeah.
Yeah, so there's not anything, any kind of broad test that you can go in. That there are some tests that are being developed, sort of looking at circulating tumor DNA, which, this is an area we're now using actually in cancer treatment to be able to determine responsive disease by looking at, because the thought is that these prostate cancer cells shed off DNA, which gets into your blood, and we can identify that. So we are using it currently in the situation of being able to see whether a treatment is effective if that circulating DNA tumor goes down. But it hasn't yet made or established a role in general screening. Some of that has to do with, obviously cost associated, but it's really not that, because I think the costs are actually pretty low for the test itself, but it's really a matter of the anxiety, the diagnostic tests that it goes through, and we don't have data to show that that makes any difference. The data that we have in screening, we have well-established data for breast, we have well-established data for colon, where the PSA has a role, and that's debatable, but that should be a discussion with the doctor. And we know that in my practice, and I think any oncology, if you look at the American Cancer Society, if you look at the American Society of Clinical Oncologists, if you look at the surgical oncologists, we all recommend having that PSA and digital rectal exam and having those regular screenings. So there's unfortunately not any easy one-stop shop testing at this point. But now that we have all of this new, genomic data, who knows, that could be the case down the road.
And be real careful with screening, because again, screening is meant for people that are at a certain risk level. For instance, you don't do mammograms on 20-year-olds. You don't do pap smears on 17-year-olds. There's an age, there is a risk requirement for testing. So if you were to go to your primary and say, hey, listen, I want to be tested for all cancers, it just doesn't exist, because you have to sort of be screened in to be screened.
Mm-hmm.
And on that point, since there are disparities, we talked about, that's the whole crux of this conversation, that African American men are twice as likely, 2.2 times as likely to be diagnosed with prostate cancer. Why not start in the 30s? Men, when they go in for their well exams or their physical exams in their 30s, or at the latest, say, at the age of 40, that in the blood work that gets done Yes, you might throw in a PSA, but why not throw in some of the BRCA1 and 2 and throw in any other kind of genomic markers that would help figure out if this person's at risk? And I say that because for the most part, given that stat, you're going to have Black people with family history of someone that has either breast cancer and or prostate cancer. So it would only serve to offer that test or even incorporate that test into those physical exams for people in that age range. Thoughts
So,
on that?
I'm gonna go back to the whole screening idea, and for instance, in obstetrics, there are people who still believe that you should be doing pap smears in 18-year-olds. And what has happened is there's been a whole bunch of people that had some pretty invasive procedures done just to find out that this is something that would resolve or not really be an issue, or we misinterpreted the screening information. uh, you know, it would not necessarily, I don't even think we know what PSAs at age 20 would actually mean.
Mhm.
It would have to be something that we would have to start looking into.
Right. I would agree. As I mentioned, the American Cancer Society recommends that for Black men, it's starting at age 45. If you have a family history of prostate cancer, especially at a young age, the consideration would be to even start maybe 10 years prior to that. So, especially if there are men who I've had with prostate cancer diagnosed in their late 30s or 40s, then their family members might have earlier screening. But to your question about, there is another one of the projects that I'm working on right now is sort of working with, there are some tests that kind of try to use some of these genetic changes that are identified and help sort of pair that with prostate cancer risk and use sort of a stratified screening approach, especially in the African American population, because if you were just to follow your typical standard guidelines of screening for Black men, as you mentioned, the incidence is higher, the death rate is higher. You want to be able to catch some of these people, but you also want to be able to have a tool to be able to identify men with prostate cancer who are African American that may still have indolent disease. And so I think we have more studies to do. I'm working as part of that in that area to be able to risk stratify people within the general populations. And like you said, using family history, where we are going with genomics, it may be a day that, a genetic counseling session is part of the primary care visits. So,
And one social thing, Dr. Dyson, I had a young lady who was a twin. Her mother passed away from BRCA ovarian cancer, from a BRCA gene, and of course, that means that they're highly likely to have had the same gene. Uh, One of the things we counsel patients is, if before we do these tests, to get your affairs in order, because I'm telling you, I've seen people get denied life insurance. I've seen other unintended outcomes of knowing that information. Not to delay it, but to please go get your stuff in order, so that when we do these tests, if you do come back BRCA positive, we're going to do all the right things for you medically, but we want to make sure that you're socially taken care of as well.
Good, very good point. Very good point. Question in the chat, just talk a little bit more about the benefits of diet in terms of how dietary recommendations in terms of minimizing a man's risk for prostate cancer.
so the big ones, I guess, are really with, there's a huge relationship with obesity. And so I think exercise, we haven't talked much about, but that is very important part of this. But specific to diet, as I mentioned, there, trying to have a majority of sort of plant-based foods, so a lot of vegetables, a lot of fruits, and really having that be the majority of your plate. Keeping your protein to more leaner meats, chicken and fish. If you're going to have red meat on sort of make that less of on an occasion kind of a thing, and trying to make it the leaner if you have the option of going to a leaner cut of beef or less fat in the ground beef or something like that. And then, like I said, limiting processed foods, trying to limit fast foods, all of the things that sort of make that taste good and keep us addicted to it is all not good for us. So, those are really, it's just a general lifestyle thing, and I'm happy to make available some sort of detailed information through your website or something if you'd like me to do that.
Right. This is a side question. You hear people often, or not often, you hear people actually going to these retreats, if you will, and you go to the Mayo Clinic and go up there for 3 days or so and have a full battery of tests done. And I'm curious in that, so people go up there, they'll stay, yes, you get pampered in terms of the spa services, but also you go through and they do CT scans and all the scans and all the blood work just to do basically like a 100,000-mile check on your car. I'm curious if in those settings, if they actually do test to assess people's risk of prostate cancer and other cancers. Do you know?
I don't know that I don't have the whole host of orders that they send in those executive sort of those um, but I would imagine that's PSA is probably part of that, and obviously the scans are going are done with the purpose of identifying things. I think that's definitely an individual choice in terms of that, but.
All right, thank you. Are there any other questions? I'm going through my chat now. I don't see any others. I don't have any last minute questions or any last minute thoughts. Dr. Moore, Dr. Baker, any wrap up thoughts or anything before we close out?
I just implore all men to visit your doctor once a year, whether you think you need it or not, to be screened of all the things that are age appropriate and to have a conversation. It's about a conversation. I should not be in a room with anyone dictating anything. It should be a conversation. And if you see your doctor every year, it will be well informed because I will be educating you along the way. So eat healthy, do all the right things. Dr. Moore hit all that stuff on the money. Just maintain close contact to your primary care doctor.
Yeah, I would emphasize that as well. That really taking an active role in your health, educating yourself about it. If you have questions, write them down and ask your doctor. They're happy to answer those questions. Establish a relationship with the doctor that you feel comfortable with and trust. If they're out the door before you have a chance to ask questions, that's not the doctor for you. If you don't feel comfortable asking the questions that you feel you want to ask, that's not the doctor for you. So find yourself someone who you can have a good relationship with. And by that continued communication, as Dr. Baker said, with regular checks, they will be keeping you up to date with, the screening that you need, what's new out there in terms of screening, because it does change, and options, and being able to have a discussion as to what's best for you, because we have all of these recommendations that are based on population, but it comes to the individual and that discussion with your doctor about what's best for you.
Well, thank you both for your presentations. Well done. And I'll pass it back over to Brother Myron Douglas at this point for any vendor presentations or the next segment.
Thank you, Dr. Dyson. So now we'll take a quick intermission, about 15 minutes, stretch our legs to some water. In this virtual environment, we can get kind of stale in a minute. So we'll be back in 15 minutes. We're going our diabetes portion of our program, and we'll have some discussions, some questions, and Q&A, and we'll go from there. See you soon.
Thank you. Welcome back, everybody, to the Arizona Men's Health and Wellness Initiative, 7th edition, 7th year in a row. Wanted to once again thank our speaker, Dr. Cassandra Moore, and Dr. Edmund Baker, both of them, for their great presentation on prostate cancer this morning. And now we move on to the second topic, which is going to be diabetes, and Dr. Baker will be on the panel, as well as two new participants, one being Dr. Danielle Gilliam. She's a graduate of Xavier University and with a degree in chemistry. And then she went on to obtain her pharmacy degree, doctorate from the University of Illinois, Chicago. She has 20 years of field experience in the field of diabetes, including clinical research and industry experience. She has over a decade of experience in the area of obesity. She recently, she completed her degree in public health, her master's in public health policy and administration, and she is currently certified as a diabetes education, medical writing, and editing expert, I should say. The other speaker we have is Eric Taylor, and Eric Taylor is a nurse practitioner, family nurse practitioner, who obtained his diploma in practical nursing from H Council, Trenholm State Technical College, and Associate of Science in Nursing from Troy State University. He later attended Auburn University at Montgomery, where he received an academic scholarship and earned a Bachelor of Science in Nursing. He was elected to Who's Who among students in American universities and colleges before being inducted into the Sigma Theta Tau International Honor Society of Nursing, Kappa Omega chapter, and the American Association of Critical Care Nurses, where he is a CCRN alumnus. He then proceeded to earn a Master's of Science in Nursing from the University of South Alabama, where he completed his family nurse practitioner program and is currently certified as an FNP by the American Academy of Nurse Practitioners. So with that being said, I like to hear and be enlightened by our three panelists on this field of discussion about diabetes.
Good morning. It's still morning. I will lead off the discussion. As everyone knows, we talked before. I'm coming to this from a more social point of view, because we have two experts on the panel with me who are doing a fantastic job discussing the actual medical and preventative parts of this. So as I start this conversation, understand it comes from a lens of the social construct as I begin to share the screen with you. And, okay, now it's not doing what I want to do here. I'm sorry, guys. Here we go. All right. So diabetes and equity in medicine. So for those that weren't here for the first session, my name is Edmund Baker, medical doctor, I'm medical director at Equality Health, as well as an adjunct professor at ASU, where I actually speak and teach in the doctoral program regarding health disparities and cultural diversity in medicine. So I'm coming from that slant during this presentation. So I want to start by giving a little bit of groundwork here, because in my class, I actually showed this slide or something very similar in front of every lecture I give, all 8, 9, 10 of them, depending on how long the semester is. And it's to make sure you understand that equality does not mean equity. They are different. As you can see on the left, everyone gets a book, right? But that book does not help two of these people reach what they need, that diploma. Whereas on the other side, you may need more help to reach your goals, but that in itself is what equity is about, all right? Diabetes, when you look at African Americans versus white communities, this is a huge, huge, huge disparity. For African Americans, we are 60% more likely to be diagnosed with diabetes. 3.5 times more likely to be diagnosed with end-stage renal disease if you have diabetes, and 2.3 times more likely to be hospitalized for lower limb amputations if you have diabetes. 2 times more likely to die from diabetes. And I said that slow because I want all this to sink into you. We're not playing with the same deck of cards. We get the same disease and we're going to have worse outcomes. Some of that I'm going to attempt to address, but again, I spend literally an entire semester talking about possibilities as to why this is true. We all understand the medical part, but we need to go beyond that and start looking at some of the social issues which lead to this. Just a brief talk about life expectancy overall. We, as African Americans, are expected to live shorter lifespans than white Americans, and you can see the disparity is even greater for white males to black males. I understand the other number includes females, which the gap is not as wide. And again, let's talk more about equality versus equity. I'm going to take a little bit deeper look at this. Now, if you have 2 patients, and the first one shows up, 45 years old, 10 a.m. appointment, arrives at 9:50. You have diagnosis of high blood pressure and diabetes, and they're on medicines for it, at least prescribed. And the blood pressure today is just a little elevated, but still okay. And the A1C, which is you'll learn very shortly, is how we measure or how we monitor blood glucose, especially in those who are diabetic. And he's here today for requesting of on-time refills. Compare that to somebody who is a 45-year-old man, 11 o'clock appointment, arrives at 1 p.m. and is diagnosed with the same 2 things, hypertension and diabetes, on the same medicines. Blood pressure today is 180 over 110. The A1C, again, how we measure the diabetes, is very elevated at 12, and not taking the prescribed medicines. So one of the most important things when we talk about these patients is not to have an implicit bias and not to assume why someone is what they are. So I'm going to break these 2 down because they're 2 very different patients, even though they seem the same age, same background. Patient number 1 is an employed male who has mail delivery on his meds, so the meds are never late, and has attempted to take the medicines. The medicines may need to be adjusted for the blood pressure, but diabetes is right where they want it to be for a diabetic patient. The second patient looks to be the same, but came to the appointment late. What you don't see is that he had to take the bus, has no transportation, had to take several buses to get there, and one was late, so therefore he's late. So just think about that. When you have a doctor who turns away patients because you're late to an appointment, that is just an absolute a slap in the face of someone who's taken a couple buses to get there. The blood pressure is high, probably because he's rushing, and also because the fact that he's not taking the prescribed meds, and that's the same for the A1C. Well, what you're not seeing is he can't afford the medicines, so therefore is choosing between eating and feeding his family and buying the medicines. So, they were prescribed the same medicine, so they were equally treated, but it's the equity portion that's missing from this. And this person is going to need help with transportation. And this state is a great thing. Access does provide help with transportation, and is going to need help with medication. So we as providers have to make sure that we don't give patients medicines that they can't afford, and work towards treating what we can. Sometimes it's not the optimal medicine, but again, this is the reason why it's important for us to understand the social construct in which we're dealing. The understanding the culture circle. The reason why this is important, and again, if you don't understand where a person is coming from, you can really mistreat them, not give them the treatment that they deserve. Food and drink. There's a lot of cultural differences between Mexican Americans and African Americans. When you have a Mexican American come in diabetic and their sugars are out of control, and you say, okay, so we're going to cut out all the bread, so that means no bread. So they'll come back the next visit and their sugar be the same level. And he said, well, doc, you told me to stop eating bread, but I eat tortillas with every meal. You got to understand what their food and drink is. And you can't necessarily tell them to stop it, right? What you can do is get them help with a nutritionist to explain, hey, listen, how about let's try by cutting it in half or use smaller tortillas. Do anything we can do to reduce the amount of carbohydrate load that you're going to get. What about those that have different traditions and rituals, right? You have people who fast because of religion, right? So we cannot tell them to have to snack 5 times a day, and they're supposed to be fasting. It doesn't fit. So please make sure that you explain to your providers everything that may be different about you. And remember, difference doesn't mean deficient. We just have to be smarter and learn how to manage your health in a way that fits within your value system. And that's how we build trust as a provider to a patient. So cultural competency and cultural humility, they're a little different. Just understand that I, as a provider, need to be culturally humble. I need to be able to recognize differences between cultures and perceptions, and I need to be able to understand that. Cultural competence, however, is institutional. If I have a clinic, I need to make sure that I have documents in all the languages of the patients that come to see me. If I'm in the middle of Phoenix and I have Somalian population, it just would not behoove me just to have English and Spanish. I should have something in the native languages so that they can understand. If not, or have somebody there to interpret for them, or having a service that can do this for me. Also, understanding diets for the people that you see most, and having people who can counsel for you, the nutritionist that can understand it and give them good recommendations instead of generic recommendations is super important. Cultural competence is how we win a lot of these battles. The obstacles of cultural competence, of course, are many, but I'm just going to talk about a few. Implicit biases. Now, if I were to see everybody on the screen and say who has implicit biases, I would anticipate that all 24 people on this screen would raise their hand. And he said, Doc, I don't have an implicit bias. I don't have a prejudice bone in my body. Implicit bias is not about being prejudiced. It's the unknowingly applying biases to anyone around you, right? So imagine you walk into Cold Stone Creamery. I just saw people talking about that. And you see a guy in there who's 400 pounds and he's ordering Cold Stone ice cream. What's going through your brain right there is a bias, right? You're seeing him, and in your brain, you say he should not be eating that ice cream, right? You don't know what this guy has. You don't know if he has an endocrine disorder or whatever it is. You don't know how they got there. Eating the ice cream could probably add to the problem that they have, but you don't understand the whole story. Understanding patients helps remove those implicit biases. And also understanding some societal norms can be overtly or covertly racist. And this is most obviously seen in policing, but it happens in medicine as well. And then identifying those microaggressions, because it is all the above. the implicit biases, which again unknowingly happens by people, the societal norms, which can really affect us, and then also these microaggressions like Dr. Dyson, no, Mr. Dyson, what do you do for a living? I'm a doctor. Oh, really? You know, there's no way you could be a doctor, right? They don't say that, but you can tell by their actions. That's a microaggression. All of this is part of a race-based trauma, which really affects humans. And we're starting to understand more and more of this, right? There's studies that started back in the early 2000s where they looked at cortisol levels of African Americans. And the reason why they did this, it wasn't because they thought just African Americans were just bad actors. What they found was in some of these communities where there were Africans moving to America in, in Seattle, in Minneapolis, even here in Phoenix, people will come over from Africa poor, not really, having the best of diets, but being able to eat, their cultural diets, and they found that, they were okay. They didn't necessarily have all the same issues that we had here as African Americans, but what they found was, as they stayed here, and their next generation fell right back into the thing. So it wasn't our genes as being African American, it was something happening here, even those that stayed with their cultural diets, right? So what is it that if we're keeping diet the same and the people are the same, what is it that's different? And a lot of thought was turned towards this whole idea of racial trauma and how that acts on the human body. So my last slide here is a diagram which I just want to go over really shortly. So trauma. When we lived in a safari or a gazelle jumped out in front of us and it scared us, our blood pressure would increase because of cortisol. Our sugar would increase because we need the energy and all your muscles. Your ability to look and think attentively is really increased because your blood flow to your brain is increased. And you do this to get away, right? So the gazelle didn't stomp you to death, or the lion didn't eat you, or whatever that thing was that caused you to be afraid. This is a normal stress cycle because your body's stressed from fear and it reacts. But just imagine if you have chronic racial trauma and you're this insidious cortisol levels that are increased in African Americans, which we found to be true, and is constantly feeding your body a constant stress state. What's happening, right? Your body has an increase of blood sugar. Again, now this happens normally for a good reason, to give us the energy to get away from something that was trying to get us. Increased blood pressure happened for a good reason, right? To get the blood to the muscles, to the brain. But just imagine this happen over time, right? And this elevated blood pressure, this elevated blood sugar leading to stroke and diabetes, the suppressing of your immune system, the effects on the pain cycle, and also serotonin, which can lead to depression, right? So chronic stress by way of cortisol plays a part, and we're not quite sure how much of a part, but definitely plays a part in this cycle of disparity in medicine. And it just requires more thought as to how this will help us in the future in treating patients who have resistant disease, which we're going to hear about with our next great presenter. Just understand and improving the outcomes. We just need to continue what we're doing here with education, and this education needs to be culturally competent. I need to be talking at a level that everyone understands. If doctors on here, they get it. Someone here who doesn't understand all the medical terms, I'm not using them so that we can have an open dialogue and is understandable, and it should be available to everybody. We should improve the access. I hear it all the time. Man, they're right down the street from a hospital, or they're right down the street from your clinic. But the access doesn't mean that they can't walk to it. It also means they may not be able to afford it, right? Or they may work and can't get there in time because my clinic closes at 4 o'clock and they don't get off until 5. So the access is not just the fact that it could be next door to you. It's the fact that I literally can't get there for a legitimate reason. And we as providers and as the community people need to increase our partnerships, because when it comes time for me to prescribe medicines to my patients, I need to have a level of trust. And sometimes, especially when it comes to COVID-19, people just don't trust you the same way as they do as when you're treating for diabetes. And even those with diabetes may not trust you. And it's important that if you have the ability to work with communities through their houses of worship, through their community centers, through their leaders of the community, is important because the trust will be sort of assumed by the people that you associate with, especially if you do it in an honest and earnest manner. And then lastly, we don't talk about this a lot in our community, but to be complete advocates for policy changes that help address issues for the concerns of our community. We need to always be on top of that. It happens as little as just being that thorn in the side of someone who has a seat at the table, or it can happen as overtly as you getting a seat at the table and being a vocal portion of that for our community. So I will end my portion of this where I'm talking about the importance of understanding some of the social impacts, which are mostly departed by the social determinants of health, or how they affect the disease. I want to pass this over to Eric, who is aptly qualified to really talk about this disease and to talk about it from a medical vantage point, and to hopefully answer some questions that may be lingering for people listening.
Great. Great. Thank you, Dr. Baker. Wonderful presentation. To all of our distinguished guest presenters here today, and to the brothers of the Arizona Men's Health Initiative, thank you for the opportunity to speak on your platform here today on diabetes. Can you hear me well? Can you hear me okay? Perfect. Again, I'm Eric Taylor. I'm a family nurse practitioner here in the city of Houston. I have a platform called Priority Male, where men's health is a priority. I focus a lot of what I do here in the city of Houston on men's health. Having been doing this for 24 years now, and NP for the last 12 years, seen quite a bit and had an opportunity to engage a lot of men in conversation here in the community, and to try to help them, motivate them to live happier, healthier lives, educate them on the importance of their health and wellness, and help them navigate their individual wellness journey. So let me, I need to share my screen here. I don't see that I have control to do that just yet. Let's see. Let me see, I don't, okay, let me pull it up. Are you all able to see my screen?
Not yet. Do you see it, Brother Taylor? I mean, you should be able to. If not, I'll make a change real quick.
Yeah, I don't see where I can. Okay, here we go. There we go. All right, here we go. All right. We're going to talk about the facts about diabetes here today. At the end of this presentation, I want to have a conversation with you men today. We're going to talk about what diabetes is, how it is treated, some risk factors and complications of diabetes, and some of the reasons of the current epidemic and how it can be prevented. Dr. Baker has already alluded to some of the cultural constructs that we deal with on a daily basis that affect what we see when it comes to diabetes. So let's talk briefly here about the anatomy. The pancreas is a gland. It's about a 6 to 8 inch gland embedded in the abdominal cavity. It rests right between the stomach, the liver, the gallbladder, and the small intestine. And its two primary goals are to help aid in the digestion of food and to provide insulin to help regulate blood sugar. Okay. Now, so what is diabetes? So diabetes is basically when your body does not produce or properly use the insulin that is available. Insulin is a hormone that allows your body to convert the glucose that you consume into energy. And this is what we need to fuel the body. Now, when you don't produce enough of this, your sugars will gradually go up over time and potentially lead to the development of diabetes. And we're going to talk about the types of diabetes here that exist. So there are two primary types of diabetes. You have type 1 diabetes, which is insulin dependent. This is usually diagnosed in children at very young age. Then you have type 2 diabetes, which is most common right now that we're seeing in our obese population and often diagnosed later in life. There is a third type of diabetes we see, what is called gestational diabetes. We see in women during pregnancy, and this typically resolves after the term of the baby, but it does place the woman at a higher risk of developing diabetes later on in life. And there's one fourth one that I would add, and I call it deniabetes, because with deniabetes, we all deny that we have any of the symptoms that are presented when it comes to diabetes. And that to me is more prevalent now than ever because people don't want to accept the fact that they actually have diabetes. Now, when it comes to pre-diabetes, this is the state where your body is starting to have symptoms suggestive of impaired glucose control or tolerance. So we typically see what we call metabolic syndrome. And again, what metabolic syndrome means is you're overweight, your blood pressure is a tad bit high, your cholesterol is a little bit high, and your glucose numbers are a little bit high. This is how your body starts to present with the pre-diabetes. And it comes before type 2 diabetes. And again, most people see these symptoms and there's sometimes we're, again, in denial about it. If you look at the cartoon here to the right with the middle column, where it talks about pre-diabetes, where your A1C, which is the magic number, you should always know if you are a diabetic or being screened for, you should always, when you leave your doctor's appointment, know where you stand from an A1C standpoint, because that is going to help risk stratify you as far as how aggressive we need to be with your diet, lifestyle modifications, medications, and things that you have control over from your diet, your culture, and just the lifestyle that you live. But the A1C for prediabetes starts at 5.7 to 6.4. If you have an A1C that falls in that category, you are at significant risk of progressing to type 2 diabetes. Again, your fasting blood glucose between 100 and 125, and the oral glucose tolerance test, which we don't do that often, but between 140 and 149. And as you can see, the normal column, less than 5.7, which we hope and aim for everyone, is what you actually want to fall under as far as not having diabetes and having a fasting blood glucose of less than 100. And then again, less than 140 on the oral glucose tolerance test. And as you can see, the diagnostic criteria for diabetes here is 6.5 or higher. So if you have an A1C of 6.5 or higher, you have diabetes. And again, I have so many patients that are in this category that are in complete denial about this condition. All right, and as you can see, the fasting glucose here would be 126 or higher. Now, let's talk about some facts on diabetes, some facts.
You're mute.
You're mute, Eric.
Sorry about that. Over 34 million people in America, 10.5% of the population have diabetes. About 26.9 million of those people, including 26.8 of those are adults. And about 7.3 million of those are undiagnosed. They have no idea they have it. They're walking around, don't even know they have it. When it comes to prediabetes, which is really starting to pick up and is really getting younger and younger as we speak, 88 million people aged 18 years or older have prediabetes, which is roughly 35% of the population. And as we get older, yes, there's a higher incidence of developing diabetes, but with the 65 years and older, there's about 24 million people 65 and older that have pre-diabetes. Now, with this slide, I want to kind of point out a few things here. So diabetes kills more people every year than breast cancer and AIDS combined. I want you to think about that for a minute. I want you to really think about that. In the next 24 hours, so this time tomorrow, 130 people will have developed kidney failure because of diabetes. Every 19 seconds, someone is diagnosed with diabetes. So every 15 minutes, you have roughly 47 people diagnosed with diabetes. Your neighbors, your friends, your coworkers. I mean, it is affecting everyone. And in the next 24 hours, over 4,600 new cases of diabetes will be diagnosed. That's more than 3 friends, neighbors, coworkers, or family members every minute of the day. I want you to do the math on that. You just think about it, okay? Those are significant. Now, on this slide here, look, this what I want to really point out is in the deep South. I'm from Alabama. So in the deep South is where we see the biggest scope of where diabetes is pretty much, I wouldn't say isolated, but is developing and continuing to grow out of control. And if you know about the diets in the deep South, you know, we eat a lot, we don't move a lot. There's some other lifestyle activities that are not always good with promoting good health that play a role in this diabetes being out of control and being one of the #1 comorbidities when it comes to death in the South. Now, diabetes is a very costly condition as well. I mean, and I'm talking billion with a B. The American Diabetes Association estimated that a total national budget was for diabetes is used in the United States is about 327 billion with a B, and that is rising as we speak. There's so many direct medical costs related to diabetes that again we're 2.3 times higher than those without disease to have issues related to the disease. And indirect costs when it comes to disability, work loss, premature mortality ranges about $90 billion. 1 in every 10 healthcare dollars is spent treating diabetes complications. This is significant. And 1 in 5 healthcare dollars is spent caring for someone with diabetes. So you see the range in which this impacts the budget that we have and the healthcare expenditures that we see on a day-to-day basis. Now, what are some of the risk factors? Now, this cartoon here really kind of puts it into perspective. And you see here the family history, being overweight, sedentary lifestyle, high blood pressure, and the unhealthy diet, how these all play a role. So if you know your family history, and this is very important that we know what our family history is when it comes to our risk factors for diabetes. And one opportunity I see we miss with this is during our family reunions. I know COVID-19 has changed the landscape and how we get together, but a lot of times at the family reunion is the perfect time to understand your risk factors. And we don't always talk about it. But if you are able to get together and they always tell you you look like or resemble someone in the family and they're still alive and well and kicking and willing to share with you their health history, you should have a conversation with them about how they're doing, because you're part of that genetic pool. And if they have a risk factor that has started to develop in them, you can be more proactive with your health to try to keep that at bay as long as you possibly can and manage it moving forward. So you can, again, get that full, healthy life. So brother or sister, have diabetes, you have a risk factor. African American, I think Dr. Baker has already alluded to some of these risk factors. Native American, Asian, Pacific, and Pacific Islander. So having a baby weighing more than 9 pounds, which is part of the gestational diabetes that I mentioned earlier, having high blood pressure, having low HDL. The HDL is the good cholesterol, and it's going to be low in people that don't move a lot. When you don't exercise a lot, this is going to be low. But the more you move, the higher this will be, and the better it will be for you overall in managing the other risk factors associated with diabetes. And the high triglycerides is another risk factor for you. So some of the complications related to diabetes. Now, again, you see this on the right here. There you have the controlled diabetes side where the guy is pretty much intact. And then you have the uncontrolled side where all of these things can potentially happen or will likely happen with uncontrolled diabetes, from stroke, blindness, heart attack, kidney disease, impotence, and amputation. And for men, I typically have those conversations with you about below the belt, because that's where I can get in, develop that rapport with you, understand, because I'm a man, you're a man, we can have that conversation, a real conversation about this. I can figure out what it is you need and develop an individualized plan of care for you, where I'm not just telling you what to do, we're talking about it, we're making sure it's culturally specific to you. Because if I just tell you to go stop this, that, and that, most people are not going to do that, as Dr. Baker has alluded to that earlier. When I tell people to stop stuff, they really don't do it. And you have to really drill down to what is specific to them from a cultural, personal aspect. But if you're able to fix some of those, you can prevent these complications from happening. But men, if we don't, they are very real. And here are some pictures. So all of those home podiatry procedures that you want to try to do if you have diabetes, I highly recommend against that. For those that go and get manicures and pedicures, please let your technician know if you have diabetes. And if it's poorly controlled, you really need to have a conversation with your doctor and podiatrist if you have one, and allow them to manage that medically. But these are some of the things that can happen when you have diabetes and it's uncontrolled when it comes to amputation of limbs. And it basically means we start chopping you down to size. And these are some of the other complications you'll see here is Charcot foot syndrome here on the left and the heel ulcer here on the right. And these all are signs of poorly controlled diabetes and complications of diabetes. Now, how do we prevent these complications? It's pretty much the ABCs. You know, knowing what your A1C is. If you don't remember anything today, I want you to know, ask your doctor, ask your provider, hey, doc, what was my A1C today? So you understand where you are within the realm of diabetes. Know what your blood pressure numbers are. Take your medication, but don't just take it and not know where you stand with the medication that you're taking. Make sure you understand where your numbers are. Understand what your cholesterol is as well, and manage that with your diet, lifestyle modifications. And if you're on medication to lower your cholesterol, take it consistently. So what is an A1C here? A1C measures your average blood sugar over the last 3 months, 90 days. If you're diabetic and you're uncontrolled, you should have it checked every 3 months. But if you're type 2 and you're relatively controlled, we can probably get by with managing it, seeing you every twice a year. But again, that's going to be the relationship you develop with your provider. Having that, again, as Dr. Moore mentioned earlier, a doctor that you can talk to, that you can relate to, you feel listens to you and not just talks at you, but has a conversation with you where you develop a shared decision plan making for your plan of care that you are going to implement. All right. And then again, have those conversations, know where your goal is. And the ideal goal is to keep your diabetes A1C less than 7, which is going to average out to an average blood sugar of somewhere around 154. I always tell patients to try to keep it around 150 or less, and you'll get that magic number of that 7 range if you happen to have diabetes. But you can see the scale here to the right and where your diabetes could potentially fall based on the scale. Be aware of your blood pressure. For those that are diabetic, your blood pressure should be ideally less than 130/80 consistently. So again, it is of utmost importance that you take your medicine, you watch your salt intake, and you do all those other diet and lifestyle modifications that are encouraged that you can do on a regular basis. It's not just taking the medicine and sitting down. Another component of this is moving, exercise. That complements all of what we're recommending from a medical standpoint to help keep your diabetes under control so you can live a happy, healthy, long life. Again, here's some things you can do to help lower your blood pressure. If you are one of those that go to the drive-thrus, the golden arches, these franchise food troughs, they're on every corner. If you're one of those that every time you look around, you're pulling into a drive-through, which I do understand because we have a very busy lifestyle, be careful because those meals are high in things that we don't need. Salt, sugar, saturated fats, and all of those things that are not good long-term. And they make them taste good because that's going to make us come back because we have acquired a taste here in America for foods that fall into those categories. But you need to cut back on your salt. You need to lose your weight. And I always tell patients, you didn't get here overnight, so you're not going to change it overnight, but let's be proactive and start now. And let's take your number, wherever that weight is, and try to lose 10% of that in about 6 months or so. All right. If you're smoking, you need to cut back. Vaping is not cleaner. Okay. Patients think all the time, well, I vape, so it's better. Nah, it's actually probably worse because when you look at how much you're consuming, you're likely consuming more than you did when you were actually puffing on the sticks. All right. Cut back on your alcohol, 1 to 2 drinks per day. Now, you can't save all your drinks up and drink them on the weekend. Men, I know how it is. We get with the fellas. We might want to have a few binge drinks. That is not good long term. You cannot do that. You should not do that. But you can have 2 drinks per day based on medical recommendations. And again, if you have blood pressure pills, take them as they are prescribed. Here, we have a very wide formulary of diabetic medications available to us on the market. Having a conversation with your provider and your doctor will let you know which ones might work best for you based on where you stand and what you want to do. But they're coming in pill form and injectable form, okay? And there are several classes to pick from, and there's probably one being developed somewhere right now. And as you sit down to eat dinner this evening, you may see the commercial. And commercialized medicine has driven a lot of patients into the office and asked specifically for that medicine. So you have to be mindful of the new medicine that comes to the market and the cost as well, because as Dr. Baker said, I don't want to prescribe you something that you're not going to be able to pay for. And then it's going to require me to give you samples from the office that I can only give you for a short period of time. And even if they work, you can't afford to copay that's $300-400. It makes no sense to give you something that's not going to work. One thing I always advise my patients is when it comes to the $5 prescription program that still exists in some pharmacies, I try to prescribe from that because you're more likely to buy those prescriptions because they're friendly to your budget. And you'll be more compliant with those as well, especially if we can pick those with a lower side effect profile. But as you can see here, we have a lot of injectables, GLP-1 receptors, SGLT2 inhibitors, insulin, combination drugs. There's a multitude of medications to pick for. And that's where you need to have a plan with your doctor on what works best for you. And you got to manage your medications. A lot of times men, we take better care of the 2 wheels or the 4 wheels that we just drove in on than we do these 2 arms and these 2 legs. And we will sometimes manage our finances a lot better than we will manage our medications. And at the end of the day, you have to take care of all of these because they complement one another, and you need to be balanced in all areas. So make sure you know what you're taking. You don't have to, I don't expect you to be able to pronounce it all the time, but write it down, have it on your phone. Save it so you can share this with someone if something were to come up. Know some of the side effects of your medication. Again, take it on a regular basis. Understand how those side effects are affecting you. Share that information with your doctor. So if there's some adjustments need to be made in the timing or dosing of the medication, that can be made to improve your compliance. Because compliance, at the end of the day, compliance is what's going to get your diabetes under control. And if you can't keep up with it because there are too many pill bottles, get a the weekly pill setup where you can put your doses in there for the times that you're supposed to take them, and that can help improve compliance. And at the end of the day, I always encourage patients to have their spouse or their significant other involved in their care, so you can share some of this responsibility and have someone invested in you being well when it comes to your diabetes, and someone else that can communicate to other healthcare providers things that may be going on with you that you may not know how to communicate, or in a state that where you're not able to communicate, they can share what's been happening. This is very important. And again, steps to lower your A1C, keep it blood sugar less than 154, blood pressure less than 130. And again, know when you need to start a statin, quit smoking, be active. The more you move, the better it's going to be for you and your diabetes and your overall health. And an active body is a healthy body. And always talk to your doctor about your diabetes. And I love this cartoon here. What fits into your busy schedule? Exercising 1 hour a day or being dead 24 hours a day? There's something you got to think about, man. But here we are, other areas that we can implement in our lifestyle modifications to help improve our overall health. Weight reduction is always at the top. The DASH diet, which is the dietary approach to stop hypertension, basically wash the salt and look for it. Sodium. A lot of patients don't understand sodium is salt. Look on the back, start looking at your ingredients on the back. Look for sodium. Think about it. Soda pop, sodium. If you drink too many of those, you're getting a lot of sodium and sugar that you really don't need. Regular exercise, 150 minutes, which is about 5 days a week, 30 minutes each time. Tobacco, reduce your stress, and watch your intake of alcohol. And if you don't remember anything, man, always remember, it's easier to stay well than it is to get well. Hashtag priority male. That is a slogan that I use on my platform where we talk about men's health issues. And because the man with the most resources will surrender all of his resources to get well. But if we are proactive in doing the things we need to do, we can avoid having to surrender all of our financial resources to try to buy back our health. So let's be proactive in all we do. Here are the resources that I use, men. And if you have questions, you can email them here for me at eric@prioritymalellc.com. You can also visit the website at Priority Male LLC. I have a private Facebook group that is men only. I have about 650 men in that group now. And we meet every Sunday. We go live. We talk about a lot of things relative to men's health. Here are the hashtags, the social media handles. You're welcome to follow me. And I want to thank everyone here on this platform for the opportunity to speak to you about diabetes here today. And here are some of the areas here in the city of Houston and Austin where I practice. I partner with my fraternity brother, Dr. Marcel Thompson. We have a men's health and women's wellness clinic here in the city of Houston, where we provide integrative medicine and care for men and women. And also I work with Dr. Umar Saeed in the city of Austin, where we take care of the LGBTQ community, and we provide PrEP, and STI treatment in that area. Feel free, again, reach out to me if you have any questions. And I want to thank everyone again here for the opportunity to speak on this platform. And I will segue into Dr. Gillum, she's gonna bring this home for us and share her information on diabetes as well.
Thank you, Eric Taylor. One quick question that I had in the chat, and that is to compare and contrast raw or natural salt versus iodized salt in terms of one's diet.
Hold up, say that again.
Comparing in terms of salt intake, to compare raw natural salt, the pros and cons of that versus iodized salt that you would typically see, like table salt.
Well, I always look at, this is just me, my logic is salt is salt. The iodized salt does have some iodine in it, some benefits, health benefits there. And the natural salt, again, people think that because of natural, I can consume more of it. And that's been what I've seen with people is that it's natural, so I can get more of it. That's not necessarily the case. So I always still go to moderation, keeping it under, I think it's 4,000 milligrams a day, but some of us get way more than that. But I really don't break down to that detail. I just say, look for sodium, look for the salt amount, and make sure you're cutting back on that. And I want to share that, give Dr. Baker and Dr. Gillum an opportunity to speak to that as well. Because that's not something, I don't hear that question often. I just tell them it's very important to cut back on the amount of salt, whether it's natural or iodized.
Thank you.
I hear a lot of people talk about natural things that are natural, and I always bring up things like arsenic. Arsenic is natural, right? How much of that you want to eat? So it's it's more about moderation than anything else. Learning to curb the excess versus trying to find alternatives for your unhealthy choices.
Great point, Dr. Baker. Thank you.
Dr.
Yeah,
Gilliam?
so absolutely. Thank you. It's a really good question because we play a lot into the marketing. But in this particular case, I would say that when you look at the ionized salt, it does have the benefit of having the iodine added to it, but it's manufactured a little differently. It is really just like sodium chloride, right? And so we talked about, well, I haven't yet, but Mr. Taylor spoke to the different types of conditions that can happen. And if you have issues with heart disease, high blood pressure, this type of refined salt might not be best for you because of the sodium chloride. That's basically what it is. Things like sea salt. So sea salt is a little better for you because it's basically evaporated seawater. And so that sea salt has minerals in it, things that you could potentially benefit from that you don't have to add or get from other sources. So sea salt has a benefit too. And then lastly, the one that I think is probably really became popular over the past few years is the Himalayan sea salt, the pink sea salt. Again, it comes from that particular region, but it too also is sea salt that has been evaporated. It's supposed to even be better for you. But like the gentleman said, salt is salt. Any of it is bad. Whatever fits your palate, but try to use as little as possible because all salt is doing is deadening your taste buds, and you're really not getting the taste of your food. So try and experiment with other spices outside of salt to awaken those taste buds.
Thank you.
Mm-hmm.
Okay, so with that, you can move into your portion of the presentation. Thanks for answering that.
All right, thank you. Let me pull up my screen here. Okay. And if you could let me know if you can see it in regular presenting mode. You do? Okay, thanks,
Yeah,
Eric.
looks
I see
good.
Eric's
Thank
head shaking. Thanks so much. Well, good afternoon, everyone. Thank you. My apologies for missing my introduction. Trying to multitask here, and it is not my strong suit because actually the brain is not set up to multitask no matter what we tell ourselves.
Just know
But
that your introduction was fabulous. You just missed it, so it's okay.
Oh, okay. Thank you. I will say though, I'm going to perfectly complement some of the things that Mr. Taylor spoke of, because he talked about taking control, being in control, making it important to you. And that's kind of where I'm going to come from. So I'm here today representing the American Diabetes Association. And what I'm going to share with you is several platforms that the American Diabetes Association has to help you stay in control, or how I like to say, and you'll see in my slides, be empowered. So we're going to talk about diabetes as a public health crisis, because it is. Diabetes disproportionately affects various ethnic and minority groups. Outside of the Native American and Alaskan population, African Americans have probably the highest level of diabetes in regards to incidence and prevalence rate. And you'll see that here. When you look at the breakdown, and I like this slide because we always hear about Latinx or Asian Americans, but we know there's a rich group of who those people are. So I wanted to present this slide to you so that you can see that. And so you see that here, about 12% of African Americans have a prevalence of diabetes. When you compare that to less than 8% of non-Hispanic whites. If we look here at the Asian Americans, they also come here from, again, what Dr. Baker spoke to earlier, they come here from their native land where they do fairly well, and then they come and they get westernized, depending on what part of Asia they come from, and then they get these metabolic disorders. And something of note to understand and to recognize is that these metabolic disorders for the Asian American population happen at a much lower BMI. And so type 2 diabetes, which was already discussed, is highly preventable. You could actually prevent having type 2 diabetes. A lot of it is contributed to excess weight. Well, what we see in Asian Americans, like say obesity, you hear that term, and what does that mean? That means having a BMI, looking at a calculation chart, of having 30 or more. For the Asian American, that BMI of obesity starts at around 26. And so they start to have these metabolic disorders like diabetes at a much lower weight. Now, if we look at the Latinx community, here in Arizona, we have a large Mexican American community. You see that they actually have an incidence rate from a breakdown compared to non-Hispanic Blacks, almost similar to the Native Americans and Alaskans. So this is a huge issue in our state and across our nation. Well, what's fueling this crisis? What the heck is going on? There's several things, but mostly I'm going to talk a little bit about the social determinants of health. What is that? Well, that talks about income, access to care, your built environment. There's a lot of different social determinants of health, and they play a huge role in how our bodies, or our being, our whole wellness impacts our health. And so then we're going to talk a little bit, or I'm not going to talk about it, I'm just highlighting because you got all this information from Mr. Taylor, so we're not going to go into great detail. Biological factors, our age plays a role. Up until recently, it was almost unheard of for a child to have type 2 diabetes. Well, we know now that's no longer the case. We have children as young as 10 and 12 years of age being diagnosed with type 2 diabetes, and that is almost always attributed to excess weight. Genetics, of course, play a role. Ethnicity plays a factor, as we talked about already in the previous slide. And then what about our lifestyles? You've heard this already from the previous two speakers. We have to take control. This is one thing that we can actually have an impact on. We might not be able to have an impact on the social determinants of health. We might not be able to have an impact on our biological factors, but we absolutely can take control over these lifestyle factors. And that's what we need to do. Now, the ADA has a mission. Their mission is to improve the lives of individuals, to cure diabetes, or actually to improve the lives of people who are living with diabetes or their caregivers. And so how do we do this? Well, the best way to prevent diabetes is, as I showed you, through a lifestyle. So what are we going to do? I'm going to step away because this actually talks about what is our burden here. It's a busy slide. I'm not going to discuss everything, but I will tell you that in the state of Arizona, there's an issue here with excess weight. So as you can imagine, that trickles down into an increased incidence of diabetes. Why is that? Well, we know that obesity, diabetes lags obesity by 10 years. So until we can get this issue with excess weight under control, we're going to always have a problem with diabetes. And when we finally do get it under control, because I know that we will, we still got a lag of about 10 years before we can get diabetes under control. I will give you this one interesting fact because I'm all about facts. One interesting fact is that if you took everybody in the state of Arizona that had diabetes, they would actually be the size of, or I should say, the citizens that live in Flagstaff and Tucson combined. So this lets you know this is a huge issue in our community and we need to do something about it. Well, what do we do? And how do I do this? Well, I put this up. In the next few slides, I'm hoping I'm going to tug at a few heartstrings. Why? Because I want this to be personal. I want this to be personal to you. Even if you yourself are not living with diabetes, you probably know someone in your family or a friend that is. And so maybe you're going to be that advocate for your friend or your family member. But what we need to know is that diabetes is robbing us of our legacy. We have a rich legacy. Dr. Baker spoke to this earlier. He talked about coming, I think he was talking about coming from Africa, but that was me chiming in late, so my abilities. But our forefathers fought hard for us. They fought hard for us to have our personal freedom. Some of them lost their lives. Some of them went to jail. We are neglecting our health. We are robbing ourselves of our legacy, of all of the things that our forefathers have done to us by not taking control and not taking control and helping ourselves. We have to do it. It is not okay for us to say, I'm not giving up my relatives. I'm not giving up my soda. That is not okay. If you know that giving up those pork or your soda or whatever else, or smoking is going to improve your lifestyle, then you need to take control of it and do it. And especially if you're over the age of 40, this is not the time to be trying to be playing around. And so what do? Let's empower ourselves. Let's empower our community. We need to stop diabetes. And how do we do that? I put this quote here with Martin Luther King Jr., who just celebrated a birthday last month. I have a dream that my 4 children will one day live in a nation where they, insert, won't ever have to deal with type 2 diabetes, or whatever you want to insert there. But we need to empower ourselves. How do we do that? A lot of resources are available to you. We have resources available on diabetes.org, www.diabetes.org. There's a lot of things that I'm going to share a few of them with you in a moment. But what we want to do is I'm asking you to take a pledge. Take a pledge to take action to stop diabetes by sharing, taking action, learning more, and giving. And I'm going to break that down in a moment to see what that means. But another quote I love that I put up, and you're going to see a few quotes. Every man must decide whether he will walk in the light of creative altruism or in the darkness of destructive selfishness. Let's walk in the light. And how are we going to do that? Well, I mentioned share. Share your ideas. Sorry, ignore that first part about the classes because I usually give a class, but we're not doing a class today. But share your ideas of how you think living a healthier lifestyle is. Maybe you have said, oh, I'm no longer going to cook my greens with fat meat. And I've tried this really great recipe. Share that recipe with others. Share dessert. Maybe if you're out and a lot of us haven't been able to be out at restaurants lately, but Maybe you're sitting out on the patio somewhere where you're social distance and getting some fresh air, and you're having a dessert with a family member that lives in your home. Split it in half, share it. Each one of you don't need to have a simple dessert. It's okay to have a dessert, but just take a little piece of it. Don't eat the whole thing. We talked, I didn't, but Mr. Taylor talked about that salt so much so that someone asked a question about it, right? Well, what are you doing to help reduce salt in your diet? I hope I gave you one suggestion by experimenting with other types of seasonings. You'll be surprised that when you start to put more seasonings in your food, that salt won't even pop up. You won't even pick it up. And then share your successes. And also here on Facebook or whatever your social media choice is, but let's start sharing. And then let's take some action. I love this quote by Denzel Washington. I made a commitment to completely cut out drinking and anything that might hamper me from getting my mind and body together. Let's do that. Let's get our mind and body together. There's a ADA has a step out walk. It's called the Tour de Cure every year. This year it is, I have it on my thing. I want to say October 23rd, here in Arizona. It's virtual this year, but we'd love for maybe even this organization to develop a team. But let's raise funds, let's raise money so that we can get the research to figure out ways to stop diabetes. And then act lean. Think lean. Switch from whole milk. I'm even going to go a little step further instead of saying low-fat milk. I'm going to say switch from whole milk to maybe almond milk or maybe oat milk, something else besides the cow. Act bold. Organize a walking circle. We're people that are very loving and caring, right? So maybe I know I'm talking to a men's group. Maybe a group of your boys. You guys go out on the golf course. Walk the golf course. Stop getting in the golf cart. Get around. Walk your feet. Move around. That's helpful. Act thin when you're out. Order an appetizer and a green salad instead of an entree. I do this all the time. I loved happy hour. Go there, you can get a couple of appetizers, a nice little glass of red wine, and I'd walk away and my bill would be less than $30. Saves money too to act thin. And then act early. Talked about that pre-diabetes. You got pre-diabetes. Don't sit around and just say, oh, well, at least I don't have diabetes. And then the next year, I got diabetes. If you have pre-diabetes, act early. Don't wait for it to become diabetes when you won't be able to regress. And then learn about things that you can do. Again, I'm speaking more around the things that are available from the ADA, but learn about volunteering. We need volunteers. We need committed people who have a passion to learning more about this disease state and sharing their information that they learn, because that's how we get all of this information around, which is why I applaud the Arizona Men's Health and Wellness Committee for putting this on, because these are the types of platforms we need to learn. We talked already about the learning for healthy tips and about the recipes and all of this stuff we already discussed. So I'll just move to the give. Let's give back. Give back to our communities. Give back to your family, because they need you. They need you not only to be there, they need you to be there and be healthy. Your family needs you, and you guys are men. You are the head of the household in just about all cases, I guess. If it's two in the household, you're the head of the household. You set the example. So give your family the gift of health. Give up the frying pan. Fried foods is not good. And you know what? Now with the invention of the air fryer, nobody should have to use a frying pan. That thing is awesome. And if you ever need recipes, give me a call. I'll give you some great recipes for the air fryer. I literally only use the air fryer and the Instant Pot. And no, I'm not getting kickbacks for giving up those brand names, but I highly recommend. And then give small steps a chance. Mr. Taylor referred to this, about the weight loss journey, that it didn't take you 2 weeks to gain the weight. It's not going to take you 2 weeks to take it off. So take small chances. I mean, it's okay. You know, maybe you lost um, no weight, but guess what? You didn't gain weight, where before you were gaining weight every year. That is a success. And so don't be so hard on yourself. And then give yourself a head start. And how do you give yourself a head start? By being here today. So I applaud everyone for being here today. So the ADA has a National Health Disparities Committee, of which I am one, which is probably why I'm here today talking to you, because they are committed. They are committed to health equity and reducing health disparities, specifically with excess weight and with diabetes. Because, as I mentioned before, it's mainly people of color who are impacted by this disease. And so this is a national committee. So this committee is across the nation. And we work with all types of centers, research centers, endocrinologists, primary care specialists to figure out what needs to happen, what type of research needs to be done so that we can get a hold of this disease and stop diabetes. And the ADA is also responsible for helping improve your standards of care. So standards of care, what does that mean? That's when you go to a physician and you have diabetes, there's certain check marks or checkpoints that need to happen. That's the standards of care. And so what was standards of care 10 years ago is not standards of care today. And all of that is usually due to more and more research, new innovations, better technology. And so this is something that the ADA also puts money behind too. The National DPP program. This is actually a very effective program. It's a year-long program. Excuse me. And what this program is set up to do is to prevent a person who might have prediabetes or be at risk for diabetes from developing diabetes, right? Prevention is key. But we recognize that, you know, it won't help the people who already live with the disease, but let's try and prevent individuals from developing diabetes because that's the best way. As I mentioned, a lot of type 2 diabetes is preventable. The American Diabetes Association also has a patient education library. So much information on there. So, you know, maybe while you are having a hot cup of tea with no added sugar to it or honey, and you're sitting back and you want to go to diabetes.org and you want to look up what education is out there, it's some really good information, very easily digestible. Most of the information is in a 6th to 8th grade, at a 6th to 8th grade reading level. So even your youth can understand it. Let's start getting this information out so people can learn. Knowledge is power, right? Is that, what was that? Oh, LeVar Burton used to do it. Reading Rainbow, I think was the name of that program. I'm dating myself, but that's okay. And he used to always talk about the importance of reading. Well, let's continue to do that. Let's continue to read. There's also a program that the American Diabetes Association is doing in partnership with the American Heart Association called No Diabetes by Heart. And so why is the American Diabetes Association partnering up with the American Heart Association? Well, mainly because diabetes is a cardiovascular disease, because having diabetes is just as harmful to your body as having a heart attack. So this is a really important program. Diabetes Food Hub. This you'd love. If you go to the website, diabetes.org, and you can put in the search box, the Food Hub, this is a really good program. It gives you interactive meal planning. It gives you shopping lists that you can adjust to your meal liking and print out tips, recipes, really good. Living with type 2 diabetes. This is I think this is a year-long program too. It's either 6 months or a year, but you actually receive emails or text messages, depending on what you sign up for, and you get information on how to manage your diabetes. And that's something you can sign up for. Now, all of these things that I'm mentioning to you, zero cost, free to you. So let's think about it. Ordinary people can do extraordinary things. We had our first African-American president, and I miss him. Who would have thought that, right? I know that my mom didn't think he was going to win, let alone did he think he was going to win a second term. So we know what we can do. We can do things when we put our minds to it. So my question to you is, what will you do? What will you do to manage your diabetes better, prevent yourself from developing type 2 diabetes, or help someone in your circle who has diabetes? What will you do? Thank you for your time and attention today.
Thank you, Dr. Gilliam.
Mhm.
Well, a great presentation. One of the things I think about when you talk about prevention is during wedding vows, people say that you'll take care of your partner in sickness and in health.
Yeah.
When you say that, you really don't expect them to be sick. You plan on, you think optimistically, you think about them being healthy. And so if people were to actually take that same approach day in, day out, working with their loved ones, family, not just the people you're married to, but your siblings, close friends, and you encourage them to make good decisions. And as you said, maybe order appetizer and a salad as opposed to an entree, then you're actually keeping that dream alive in terms of them having a minimal chance of actually suffering some kind of major sickness or illness, because they're making good decisions day by day instead of just waiting for them to be in that boat of needing a medicine cabinet and then need to be on medicines for the remaining part of their life.
That's a very valid point, Dr. Dyson, because you talk about what are you doing for your partner. So maybe your partner has diabetes, but you don't. Then if your husband has diabetes, then you, as the wife, you take the initiative to change the whole family's lifestyle, right? To make it easier for him, because he doesn't want to be the only one at the dinner table with a salad or, something low carb or low fat, But if you make it a family affair and you change everybody's habits, it makes a difference. And so that I agree, that's what that marriage vow is about: sickness and in health, to death do you part. And if you don't help your spouse or your partner, that death do you part might come sooner. About on average, people with diabetes, life expectancy is decreased by 8 years. 8 years.
Yep.
Great
All right.
presentation, Dr. Gilliam. I'd just like to add that men, we suffer in silence. We don't always know how to articulate or communicate some of the challenges that we face on a day-to-day basis. We live every day to do the things that we do, provide, protect. And a lot of times we'll put our health at the bottom of that priority list because we want to take care of everyone else. And sometimes we can be stubborn, and I can speak honestly on that because, I'm a man, and we won't always listen to the advice of our spouse sometimes because we think they're nagging. So, man, I just ask you to keep an open mind and try to look at the big picture. They've been placed in our life for a reason, and they want to see us live a happy, healthy, long life together. And to get into those golden years, into that chapter of life where you can now reap live off the benefits of all that you put into life while you've been, doing your normal working years. But just try to keep an open mind about it, man, and be moderation in everything. This is not absolute. To say that you're going to just stop and do that, let's be real. It's not going to happen. But if you can keep a delicate balance and be consistent, the key is being consistent, holding yourself accountable. Your spouse can be your greatest accountability partner in this, journey, and you can help one another. And that's what I kind of encourage all the time. I try to push that all the time, but we still have some challenges in that area. A great presentation, everyone.
Yeah.
And Eric, one of the things I remember from looking at your graph that you had showing how in the Deep South, you have all the major or a greater issue of diabetes than say up in the Northwest, is that my time I was down in Memorial School of Medicine, and being down there in the South, it was more of a common thing there than I ever experienced in the West Coast, that people would order their dessert before they actually order their meal. And and on top of that, I'd have people at lunchtime ordering dessert on a regular basis at lunchtime, in addition to lunch. And then of course you get it in the evening too. So it's just a huge step up in the sugar intake.
Very true, Dr. Dyson. It's cumulative over time. And like you just said, if every meal you end it with a dessert, you think about the amount of sugar, the amount of salt that you've consumed on a day-to-day basis. And then you think about, again, the sedentary lifestyle, all these creature comforts we have that keep us from moving. You know, you can speak to turn on your TV. You can talk to Alexa. You can talk to all of these technological advancements that don't allow us to move like we used to. We don't go outside. We're vitamin D deficient. We're almost scared to walk. We're scared of the sun. We're into the garage, into the house, and that's it. And we don't move a lot. So you factor that in along with the lifestyle, and this is only going to get worse over time. So we have to be consistent and intentional with keeping our health at the forefront.
And Dr. Gillum, as you mentioned, accountability partners, that each spouse has to not only take care of themselves, but the other. And so my parents used to say that if one is healthy, then the other is healthy, at least more so than my dad would say. So if my mom went to the doc and she got a good report card, he would assume he's eating the same thing, drinking the same thing, so his health has to be just as good. But it needs to be stressed that the accountability means that you've got to push not just what takes place in the home in terms of what the other is eating, but also push them to go get their evaluations on an annual or biannual basis.
Yeah, I agree. I had the opportunity a couple of times. I was blessed with the opportunity to participate, speaking once on diabetes and the second time on obesity for, it's no longer the Tom Joy in the Morning show, right? He's no longer on the air, but he used to have a segment called Take Your Loved One to the Doctor. I love that concept, and it speaks kind of to what you were saying, Dr. Dyson. I think, can I address one of these questions in the chat?
Sure, by all means.
So Eric Bailey asked, any thoughts on the ketogenic diet? And initial research indicates that it can reduce or eliminate type 2 diabetes. First, let me tell you, there's no such thing as eliminating type 2 diabetes today, only because the amount, when you are diagnosed with diabetes, you have probably close to 80% or more of your beta cells, that's the cell in your body in the pancreas that Mr. Taylor so eloquently showed you where it's located. In that pancreas, they have beta cells. That beta cells produces the insulin that gets released after you eat or when your blood sugar level goes high to bring it back down. When you have diabetes, that beta cell is just, it's about 80% destroyed in regards to the releasing of insulin. And so you still have some workable beta cells, right? And so if you do some things, take medicine, you'll do fine, hopefully. But the amount of beta cell regrowth will not outgrow the beta cell destruction. And so you will always be in this negative count. And so you don't reverse diabetes, eliminate diabetes. You can manage it. You can even manage it without medications, depending on how aggressive you are, but you don't reverse the disease. It's a chronic disease, and which is why prediabetes, being proactive there, is so important. Because if once you get diabetes, then you're there. But when you have prediabetes, you can make a difference at that point because you still have more beta cells being releasing insulin. And then in regards to the ketogenic diet, the ketogenic diet, like all diets, so as that word diet, is exactly what it is. And the reason it's called a diet is because more than likely it's short term. Any type of diet that you go on will help you reduce weight, which in terms will help you manage your diabetes better. But what I'll tell you is that be careful when you're doing a diet. If you're going to do a diet and you're going to stick with it forever, then okay, great, let's do that. But if you're going to do a diet and you're going to stick with it for 5 weeks, 8 weeks, heck, maybe even 6 months, the moment you stop that diet, guess what happens? You're going to regain the weight, and sometimes you might even gain back more than where you started. So I caution you to really think about this ketogenic diet. And then there's some question marks around the ketogenic diet in the patient with diabetes, because the ketogenic diet is pushing a lot of stuff into your having your kidneys work extra hard because you got all that protein. There's only a certain amount of protein that you should be ingesting, and that ketogenic diet is different. So if you have diabetes, you might want to have a conversation with your healthcare provider. Have him look at what your kidney function is first before you start taking on this ketogenic lifestyle. And I don't know if the gentleman had any other feedback in regards to that question.
And so when I say a normal diet, I'm saying this generally. A normal diet or normal way that we have eaten over time has been about 50% of our diet has been carbohydrates, 30% proteins, 20% has been fat. And we adjust that depending on disease states and depending on what type of new thing we're trying. When you go to ketogenic, you're really driving that protein, as Dr. Gillum said, to a really unhealthy level. And over time, while your sugars are going to look great, your kidneys will not, and so you're still going to have issues that you didn't anticipate. So again, it's all about moderation, and yeah, curb your carbohydrates down to 40%, down to to another level. You don't necessarily have to go to 0 or even to 20%, which would be, in my opinion, problematic.
I'll also tie in there in regards to that protein intake, as Dr. Gillen was saying, in terms of the stress on the kidneys. If you go back and look at studies from World War II and how when the Nazis took over Norway, they took over all their livestock. And so doing so, the heart disease risk and death from heart disease plummeted during those 3 years or so until the Nazis were defeated and the Norwegians got their livestock back. And then right afterwards, their heart disease risk and everything else went right back to where it was. So excess protein can actually cause some problems to your health as well.
Yeah, I'm so sorry I'm late to the chat box. Eric looks like he's been on top of it. My apologies, everyone. I saw that someone talked about kids creating healthier eating habits. I can help you with that. I had children. I still have children. I can't think of her first name, but Seinfeld's wife had a cookbook. It was a dessert cookbook that incorporated vegetables in it. And the food was actually pretty good. So maybe look at that to help them with that, but making them part of the cooking process. Depending on how old they are, you might not want them to handle a knife in the kitchen, but they can definitely do something, have them crack an egg or whatever to help you while you're cooking. Having them in the kitchen develops those habits early on. And then also telling them why they're eating the food, right? Don't just say because I said so, which is how I grew up and actually to some extent how I raised my children. But tell them why this is healthy, why this broccoli is healthy. Heck, I don't know if you've seen the information. I don't really like broccoli like that, but there's a study that came out that showed that there's this compound, and someone on the call might know the name of it. I can't think of the name of it, but it's a compound, a substance that's in broccoli that actually helps with the aging process. So guess what Danielle has committed to do? Eat broccoli every day, because I want to help age with this age process. So, this help telling them things that are beneficial to them will really make a difference. So make it fun for them. In regards to exercise, I forced my kids when they were younger to go out to play. I forced them to. I literally locked them out the house. They will knock on the door. I'm like, you can't come in. It has not been 15 minutes yet. Figure it out. Give them some chalk. Show them how to do a hopscotch box. Do some things with them that you probably used to do when you were coming up. Not necessarily ding dong ditch. Don't do that, especially not in a gun carrying state. Let's not do that. But you could do some other things. Jump rope. Jump rope's an awesome exercise. Really good for you. Do some things like that. I think those are some suggestions that I could give, and I could probably give you more, but I'm not going to take up that much time, that you could do to create a healthier eating, long-term eating habits and exercise habits. Both of my daughters are vegan. I'm not that committed to the cause, but they're vegan and they do very well. They actually read labels and they're like, oh, I can't eat this bread because it has egg. And I'm like, how much egg can be in there? Mommy, it's from an animal. But you can do it. Hang in there.
Just wanted to comment, again, was asked, he says, well, we practice keto with a higher fat, not protein. Again, those ratios are this is what we are. We're humans. We work off of glucose. Not to say that that should be any higher than what I stated earlier. It can be
Mhm.
a little bit, but to replace carbohydrates with fats is equally a terrible idea, especially long term.
Yeah, that fat can be, especially if it's animal fat, right, Dr. Baker? Plant fat
Yeah.
is healthier, but most people don't eat plant fat, especially during that ketogenic diet. And that fat that you might have in those high protein sources like red meat, they're detrimental to your heart.
They're as sticky as some of the glucose in your vessels.
Mhm.
Absolutely, this can be
And
catastrophic.
real quickly, with regards to the COVID, we're not sure how this is going to affect health going forward, but we can see that it has provided a very convenient excuse for people not to move around. And I do understand that to a certain extent, because you don't have to go to a gym to exercise. You can exercise in your community. If you have a smartphone, it is calculating everything you're doing already. You're taking every step you take is being calculated. And if you can get about 10,000 steps a day, which breaks down to about 5 miles, that will be ideal, along with trying to prepare most of your meals at home. I mean, a lot of the stores now allow you to shop online and pick up your groceries without even have to go in the store, contactless delivery. So with that said, with COVID moving forward, again, people are consuming a lot more alcohol now. We're seeing that. Depression is up. And again, the consumption of processed foods, because just the way we are right now, people are using more of those. That will likely have some negative impacts on our health moving forward. And I would always advise patients, again, balance is the key. Eat a diet that is culturally specific to you. Control your portions, buy a scale, weigh your food, more fruits and vegetables. Make sure your plate has more fruits and vegetables on it, nothing touches, and there's no overlapping. I always give patients that don't want to do all of that, you can use your fist. Unless you have like Incredible Hulk fist, your fist is a pretty good measuring tool. You can say, hey, this is a pretty decent portion size, and maybe use that to measure out your foods without having them touch or overlap, not getting seconds. And don't eat late at night and lay down on that food. You want to stay up at least 2 hours after that meal to reduce the chances of any reflux. And again, 3 meals a day if you can. Hydrate well, drink half of your body weight in ounces minimum to be considered adequately hydrated. And realistically speaking, if you're going to have a beverage that has some sugar in it, no more than one a day. You know, those things along with the exercise is a very logical way of looking at life without trying to be under the restrictions of a keto diet, a Daniel fast, an Atkins diet, or any of those other fad diets that are out there that most of us are not able to keep up longer than 6 months. So balance and consistency and being intentional are the key in keeping this where it is, your life, your health where it is.
Yeah.
Also, in regards to COVID, one thing we've seen is the increased number of patients that actually have, or people that actually have obesity. So as a pediatrician, I have a large portion of my patients actually becoming overweight, and those that were overweight are now obese, as well as the parents, and gaining, 15 pounds since March of last year for both kids, as well as, the parents are picking up weight. So a lot of snacking, also a lot of gaming, such that people are sitting around because they're not getting out anywhere. But to that point, I always tell parents, and to have their kids eat carbs before lunch. So lunch might have bread with their sandwich, breakfast they might have pancakes or cereal, what have you. But after lunch, in terms of snack, dinner, and dessert, no carbs. And in doing so, it forces them to make up the difference with ideally more vegetables and ideally eat less because they get frustrated and get up and walk out of the kitchen. But all that will pay dividends down the road for people.
I see something in the chat in regards to what can I do at age 53 to kind of prevent some of these conditions that your parents may have had. So I will tell you in regards to a lot of these metabolic disorders, genetics actually loads the gun, your lifestyle pulls the trigger. And so even though you might have family members that have diabetes, excess weight, it doesn't mean that you have to get those too. You just have to manage your lifestyle. If you remember those factors I said that determine our health, I talked about the social determinants of health, the biological factors, and the lifestyle factors. Remember, that's the one I said that you can absolutely have impact over. And so I would just say, look at what you're doing today, from how you eat, how you approach your meals, and how you engage in physical activity and what types of physical activity. I always say that in regards to what the data supports, that once you get past a certain age, and I'm going to say that 50 is that age, you want to do a lot more weight bearing exercises than just the cardio, because you want to make sure that you are keeping that muscle together. And a really good exercise for you, I always tell people, do a lot of squats. The reason I say that is because when you do get older, and I'm talking about like in the 70s and up, Lord willing, that, that's the one thing that will usually take people out of their homes, their inability to get up and down from a sitting position. And that's huge, right? Because if you can't get out of bed, you need help out of bed. If you can't get up and off the toilet stool, you need help with that. So you need that help. Well, doing those squats will help keep those muscles that, help you with that intact. So I always call my mom, did you do your squats? So that's just something to consider. But yes, the lifestyle. Absolutely, that's what you need to focus on. And even if you have a really healthy lifestyle now, I'm sure there's some other things that you can do to improve it. So that's my suggestion. I don't know if the gentlemen have any other suggestions.
No, we've been hitting on them all along, and the fact that you're 53 with no problems means that you're probably made some pretty good decisions up to this point. So, taking some of the things discussed today and adding it to what you already do will probably be just fine.
One of the things I see here in the chat I was asked to mention is about how the National Kidney Foundation recommends annual screening for diabetics for kidney disease. So it's something to keep in mind when you go into for your annual check.
Glad to hear you're doing squats, Winston. Keep it going. I brought my dog.
All right. And any other thoughts, any other comments? Dr. Gilliam, did your daughters finish Xavier, your alma mater, yet? Did we lose her?
Like she stepped away.
Oh.
No, I'm here. I just put myself on mute because the young lady was coming to take my dog out is here, and it was a lot of background noise. I'm sorry. What did you ask me?
I asked, have your daughters finished Xavier, your alma mater, yet? I know they were going into medicine.
Yeah, so I have two beautiful daughters, which you probably read in the intro. My oldest is 22. She graduated from Xavier University May virtually last year. She's now working at NIH, doing post-bac research, and she is going to go into medical school. I actually had her talk with Dr. Baker before. He was helping her to possibly get into a program with University of Arizona. But yeah, she's now restudying for the MCAT, and she's going to retake it again in June. And my youngest baby, she's 21. She's a junior, also at Xavier, my alma mater, and she's she's double majored in sociology and history, and she's going to law school. So
Okay.
I'm so proud of them. So that's why I brag on them all the time, because that's the only thing that's in my life right this moment. So I brag on my children a lot.
Congratulations.
Thank you.
You're welcome.
There's a question about diabetes and eyesight. So as we've talked before, sugar, glucose works on those small vessels. So as those vessels are constricted, so goes your eyesight. And some of that's reversible if not done for a long period of time. But as those vessels start to wear out and remain constricted, some of this eyesight does not return. So that's where the maintaining of a lower level of glucose daily helps benefit people with diabetes and eyesight.
And
There's
then also, go ahead.
oh no, I was just going to say one of the things I do when I counsel patients to get them to understand, who here drunk Kool-Aid when they were growing up? So if you took just a packet of Kool-Aid, depending on who you were, there's two types of Kool-Aid makers, right? There's the one that put the powder and the sugar in first, then add the water, and then there's the other ones that don't know what they're doing, who puts the water in first and then the sugar in them. Yeah, they don't know what they're doing.
Sugar.
But I'm of the first camp. But I tell people to think of it that way. Like if you have Kool-Aid and what normal blood would look like would just be Kool-Aid in that water, right? The consistency of it, the flow. And so that consistency flows very well through your blood vessels. But now let's start to add sugar. And it starts as the more sugar you add and the more sugar you add, the thicker that Kool-Aid gets, right? And that means that your heart has to pump harder to get that thicker liquid through your blood vessels. And so, as Dr. Baker said, those smaller blood vessels get impacted first. And so, blood touches everything in your body, guys. And so, when your body's trying to always push these things through your blood vessels, if it has a lot of sugar in it, it's not only going to deposit, like Dr. Baker said, on those vessels, it's going to have a hard time getting through. And that's when you start to have the loss of sensation in your feet and your hands, because our extremities are the furthest part from our heart. And so if our heart is having trouble pushing the blood through, then your extremities are going to be the first ones that actually get impacted.
Yep.
That's
And
that's an illustration I use.
And I would just add that if you are diabetic, you should have a routine diabetic eye exam along
Yes.
with a diabetic foot exam with your regular appointments with your doctor to look for those, as we call them, microvascular issues that could potentially happen in your body. And if you can get ahead of those, tight glycemic control, a tight blood sugar control, taking your medicine on a regular basis, knowing what your A1C is, and being consistent in your diabetes plan of care, you can keep some of these things from happening. But when they're consistently out of control, uncontrolled for a long period of time, again, the retinopathy we see with the blindness happening, poor circulation in your lower extremities leading to amputation for men, love life issues, below the belt issues, heart attack, kidney disease, all of these things can snowball on you and can all of a sudden happen all at the same time. And so just being proactive rather than being reactive is the key here, and staying on top of your health.
Yeah. Empowerment.
Also,
Yes.
and all of what they're saying, realize that it's those small vessels, as Dr. Gilliam said, the know your heart, just like you know your diabetes. Understand that both sugar and cholesterol build up inside those vessels. So those thin micro vessels that Eric was just talking about, those that are far away from your heart, even when you get into, like I said, the penis or your eyes or your fingers or your feet, those are the areas that get affected first. So you manage your sugar, you manage your exercise, your diet, and ideally you keep those vessels pretty open so they can those limbs or those areas they're feeding will last you a long time.
That's a really great point.
Yes.
Because I don't want to use the word impotence, but I'm going to use the word impotence.
Yeah, that's
It is
fine.
what it is, Doc.
Is a complication of uncontrolled diabetes. And I know our men like to say, oh, well, I'm just going to pop my aphrodisiac. Well, Viagra is not an aphrodisiac. It is a vasodilator. And that's why it helps, because it opens up those constricted vessels that is causing you to have issues. But guess what? You might be able not to have to worry about paying. I don't even know how much Viagra costs now, but I know back when it came out, it was like $30 a pill. But you might not even have to worry about spending that money if you do better and manage your diabetes. Increase your reduce your insulin resistance by getting some physical activity in. These are some things that you do that benefits your entire body. And the one thing I forgot to mention, sleep. Gentlemen, would you agree? Sleep is the missing link a lot of the times, because we're in this society where we think that, oh, people look at us great when, we brag on how little sleep we got. That's not a good thing. you need to rest. And that's an issue. Lack of sleep and lack of fiber in our diets is something that's going to kill us.
Great point.
On that note, less than 7 hours of sleep will actually shorten your life expectancy. That's
Yes,
for
sir.
adults. That's not for kids. So
Yeah.
I shoot to get 7, but just know that if you do go through sometimes busy schedules or a busy season in your career, your life, that you have to get less sleep for a week or a few weeks, just know you need to turn around and make that up. But it can't be on and off, 6 months no sleep, 6 months sleep. It should be pretty consistent. Like I said earlier, it's all about consistency.
Yes, sir.
Any other thoughts before we wrap it up? Well, I thank you again, Dr. Baker and Dr. Gilliam and Eric. I appreciate all your time you guys put into your presentations and being available to enlighten us. Even those that are watching this on the recording for some time later in the future, I pray it's enlightening for them as well. So I'll pass it on back to you, Brother Douglas.
Thank you.
Pleasure.
Thank you.
Thank you for having me.
Our pleasure.
Wow. Thank you, Dr. Dyson. Wow, what a great informational session about diabetes. I learned a lot today. And, just to be proactive, I think also too, it's a little bit of discipline as well. Dr. Gilliam kind of remind me I can no longer drink red Kool-Aid. So, so I got to start getting back on the water intake as much as possible and cut down the sugar and the sodium and everything else. So definitely looking forward to making a transition in my diet. But let's go ahead and move on to our program here, and we're almost at the very end. And I want to to introduce some awardees regarding what we do here in the community regarding men's health. And first of all, I want to introduce 2 great individuals that has worked with us in the past and even current regarding men's health issues in the Valley and with the conception of the expo as well. Our first person I want to introduce, this individual used to be the director of patient services with the National Kidney Foundation. He's been working with us since 2016, and he has been a great partner with some of the programs and some of the events that we have shared in the past. And as I mentioned before in the beginning of the program, the National Kidney Foundation was one of the first partnerships we had outside of Mayo Clinic's relationship. This gentleman has been great. We had some great conversations. We shared some great ideas, and we just want to recognize him and what he has done in the past with us here at the Arizona Men's Health Awareness Initiative and the Expo as well. So James Ivy, I'd like to present to you, which you already have, the award for recognition for your great work and partnership. And we appreciate all what you have done for the Expo in the community as well. James, do you have any words, any comments, anything you'd like to share?
Yes, thank you, Myron. I want to echo what Myron said about how strong a relationship there has been between the Men's Health and Wellness Expo and the Kidney Foundation. And back when they started having the expo at the Mayo Clinic, the Kidney Foundation had been doing free community health screening for diabetes, heart, and kidney diseases going back as far as 2001. And historically, the people attending the screenings were 2/3 women and 1/3 men. And that has been an historical trend throughout the time we've been offering screenings. And so when I saw the Men's Health and Wellness Expo, I thought, wow, here's a group that could help us try to increase the utilization of these preventive health resources by men. And we set up an exhibit at the expo. And after that, we had a lot of promotional and screening delivery help from Myron and from Erica Luna and from Andre Watkins. We conducted screenings at the First Institutional Baptist Church, the South Phoenix Missionary Baptist Church, and other locations. One year, the A. Philip Randolph Institute had their annual conference here in Phoenix, and Erica came and helped me work an exhibit there. And then there was an annual conference of the Arizona Council on African American Affairs that was the same day that the Kidney Foundation had a retreat scheduled for children at camp up in Prescott, children with kidney failure. So Erica and Myron arranged to set up an exhibit there that combined the Kidney Foundation and the Health and Wellness Initiative in one exhibit, and inform the attendings, the people attending of both our organizations. So this has been a mutual effort to increase health resources for men and their utilization of it. And I am proud to be connected with you, and I appreciate all the mutual support that your organization has given. Thank you.
Thank you, James. We appreciate your support always. And we still continue that partnership with the National Kidney Foundation and looking forward for new projects and new events down the road. Thank you so much. All right, our next and our final awardee, which we already seen earlier today, but this individual is a medical director at Equity Health. He's an OBGYN by medical practice and profession. He teaches at ASU as a professor, and he has done a lot of COVID-19 and vaccine awareness since March of 2020. You may have seen him on television, locally here in the city, or also on a national scale. This individual always is out in front of the fight and always making the example of what good health should be and good health education should be conducted. So I want to introduce our Health Civic Awardee, Leadership Awardee of 2021, and that's Dr. Edmund Baker.
Thank you so much, Myron. I just want to show everyone this award here. It's absolutely beautiful, and not just will hold a place on the shelf, but definitely in my heart. These last 12 months, and actually a little bit longer than that, have been just absolutely horrific for everyone. I remember the first time I actually spoke in public about this disease was back in March of last year, when I was interviewed by ABC, and literally a week after that, we did a telethon on their. They streamed it live and had it live on ABC 15, where we spent several hours answering questions about COVID. And you remember back then, we didn't know anything about COVID. We were still learning. I literally had my cheat sheet with me, and I done a lot of research to try to understand what was known from all the things that have been happening in China. And now here we fast forward a year later. I just want to say that, COVID has done something for us, and hopefully we can capitalize. I got into medicine, as Mr. Douglas tells you, this was my second career. I got into it for a reason, and that is I want to make a difference. And COVID has shown the light on the healthcare disparities that we knew existed for so long. African Americans have died twice the rate of white Americans, and we need to do something. And so, as I spoke, every time you hear me speak, I say the same thing. Hamilton has belayed the term having a seat at the table or being in the room when it happens. And that's so true with this. We need to be there when these decisions are made about our community, about diabetes care, about on these insurance panels, so we can talk about what meds and what things will be paid for, such as instead of paying for a different expensive insulin, let's give people a nutrition or diabetic counseling. Things like this can really go a long way. But a lot of what's happened with COVID is coming to a crust, and everyone sees in the news the disparity that is with vaccination. It is, if you go to any of the sites where we're doing vaccinations, you see that people don't look like us. They're not black and brown people getting vaccinated. And there's several reasons. If I were to give the reasons, think of a chair with 3 legs. One leg is the actual supply of the vaccine. There's nothing we can do about that, right? That's going to come when it comes. We can't really change it. The other is the access to the care. And I'm telling you, if you sit at these places, we are not there sometimes because of access issues. I talked about it before. If you don't have transportation, you got to take 2 buses to get places. These are things that need to be worked out. And thank goodness with some of the partnerships with Access, we have found solutions to some of the transportation issues. And the last part of that, the third leg of this 3-legged stool, is the willingness of someone to get vaccinated. And without education, that doesn't happen. Even amongst providers, I've seen people not getting vaccinated because of reasons which, I could not even put a finger on. I hear people talking about implanting of devices. I hear people talking about this has happened too quickly. And usually after a 30-minute seminar, I can really talk people around some of the issues they have. And that has been one of the big blessings that I've had over the past year is the education. One thing I want to bring up to everyone who's listening here, there's been an issue, as I just stated, with the amount of people who can receive the vaccine, especially in our communities. If you've been listening to the news lately, there's been a lot of talk about these micropods, and I am part of that small group of people who've come up with the idea, who are publicizing the idea. And again, this is not my project. I'm working with other people, and we are going to be in the cities. We're going to be bringing the vaccine where everyone is so that everyone has access. And where everyone comes in play is we need volunteers. We need organizations to volunteer, to say, hey, listen, this is how we can support this effort. We need people to volunteer because we need people to guide traffic or help register people. So this is all hands on deck, and I'm reaching out to everybody now before you see even more of the official ask come out. This will be coming. You can say it's coming from me or anybody on our team, but this is something that is going to make a big difference with our communities, hopefully keeping us healthy and making us safe for the rest of this pandemic. Thank you so much for this award. I will continue to fight the fight. When COVID is gone, there is something else that's waiting beyond there, and I'm ready to attack that as well. Everyone, please have a blessed day. And again, thank you.
Thank you, Dr. Baker. We appreciate all your work and help and assistance, and definitely will try to play some role in helping some volunteers who will run that process with the vaccine as well. So thank you for your work. We appreciate what you do in the community. We really do. Also, I'd like to kind of quick plug in. We do have our next Men's Health quarterly event. It's coming up in April. This event will be named Opening Conversations to Tackle the Silence, Men's Health. That will be April 26th at 1 p.m. to 2:30 p.m. We'll have a moderator and a couple of experts on a panel to start developing a conversation to how to talk about our health, how to communicate that with our spouses and loved ones, and also too how to talk with one another as men, to making sure that we all stay in the mindset of education when it comes to our health and health challenges. So with that being said, I'm going to turn it back over to Dr. Dyson that kind of closes out on some closing remarks. And once again, as chairman and co-chairman of this project, I want to say thank you for all the volunteers. Thank you for the sponsors once again. And this is an awesome event. I learned a lot today. I think a lot of people have as well. So I'll turn it back over to Dr. Dyson, and they kind of close out and take us home.
Thank you. And as Myron said, thank you for all our sponsors. Thank all the speakers, all the people behind the scenes that help put this together. And I pray that everyone had a chance to get all their questions answered. And if not, still reach out to the individual speakers, or if not, to Myron directly to get any last minute questions answered. And those who are watching the recordings, look forward to hearing your opinions and your input in these future conferences that we have. So all the best, everybody. Thanks for spending this Saturday with us, and hopefully taking home something from this time that you spent away from the other things you could have been doing. Have a blessed Saturday, and we'll see you at the next one. God bless.